So, just a very short introduction to this program of Raise and Rise. Very good morning to you all and Happy New Year. I welcome you all to this New Year's with a new forum of interaction wherein we are striving to achieve an interaction platform of learning for both students and teachers. This forum will help PG students to get familiarized to their teachers, and we all know during the exams and all of a sudden when they face the examiner, half of their knowledge evaporates immediately on the first question because they are not familiar with the process. So to make them more familiar with what happens, the way they have to present, the way they have to interact, and in fact, I have always been telling my students that you can actually guide the examiner what to ask many a time. So this will help and it will really familiarize them with the latest developments, surgical techniques, in addition to getting to know about the faculty. And I'm sure it will be beneficial to all of us. We all, after an age, stop reading books every day or going to the literature. But this young brigade, because they have to pass their exam and they have got lot of appetite to learn. So they, in turn, rather than we teaching them, quite a few number of time we gather knowledge from them, and it acts as a stimulus for us also to go into the detail and depth of the subject. So I think it's a very good beginning to the new year, and I really appreciate the effort of the new secretary, Dr. Rishi Nair, who has actually planned this program, and a very strong. Fortunately, this time the Northern Council is very strong, very strong. Sanjay has been very actively associated, and everyone, including Gautam and Dr. Banga, have been helping us out to make this program. After all, we all understand the main essence of of any society is the academic activity. And of course, I will not go into the detail of the other programs which are there. As far as the Raise and Rise is concerned, we are planning to have three or four such meetings, and depending on the PG's response, because after all, this program is mainly for students. So depending on their response, we can increase or scale it down. So this is the first meeting, and I would request all the teachers, all my seniors, to, I would say, to suggest or to order their PG students and the residents and the consultant in the department to join this platform, and we can always contribute to it, I'm sure. And with these words, I would like to hand over to Dr. Rishi to run the whole program.
Uh, Thank you, sir. More than me, I think Dr. Sanjay Sureka is going to convene all the session. I would probably come for the vote of thanks in the end. Dr. Sureka, you can take over from here.
Yeah, good morning, everyone. So, this is a unique program format, uh, as in shortly briefed by our president, sir. So, here, our unique concept would be the one presenter would be there, either PGs and some senior faculty members, and other group of PGs will interact in between with the faculty who or the PG who is presenting, and they can share their opinion, and the chairperson or experts will give their comment at the end of the session, end of the specific session. So we have five parts. One is first part is case presentation, followed by journal club, and then there is a surgical craft videos, and then next two part is soft skill development and drug focused spotlight. So to begin the first proceeding, I would like to welcome our chairperson for the first session, Professor Amlesh Seth sir, and Dr. Uttam Mete sir. I think he is. I'm not sure he has joined or not. I have sent a message, but still he is not on the online probably. And Professor Dr. Rajiv TP sir. So, and for our first presenter, we would like to invite our third year resident from uh, uh, Shabdajang Hospital, and one he will be the main he will ask the question like an examinee from the second year who will present the case from RNR hospital. So from RNR hospital, Dr. Shankit Sharma, he's here probably. Hello, Shankit. Am I audible?
Yes, sir. Hello, sir. Morning, sir.
Yeah, yeah. So you have to share your screen, or you can ask, you can present your case accordingly. And from VMCC, Dr. Hardeep Singh here. Hardeep, Hardeep, am
Hello.
I audible?
Yes, sir, you are audible, sir. Am I audible, sir?
Yes, yes, yes.
Thank
So
you.
with the permission of the chairperson, we can start the case, sir.
Yes, please go ahead.
Yes, go ahead. Just those who are the participant, just keep your audio and video on. Rest all can keep themselves on mute and probably keep the video also down so that the participants are visible on the screen. Thank you. Please go ahead.
Right. So Samkit, can you start your presentation?
Yeah, sure, sir. Is my presentation visible, sir?
Yes,
Yes.
yes. Yes.
Good morning, everyone. I'm Dr. Samkit, a senior resident urology from Army Hospital RNR. The case details are as follows. Case is 22 years old, unmarried man who is a university student from Gurgaon on suprapubic catheter presented with chief complaint of inability to pass urine per urethral following an accident 6 months back. In history of presenting illness, patient met with an accident where a tree fell on the patient 6 months back, following which he had inability to pass urine per urethral and associated with lower abdominal distension and pain, for which he was catheterized, but could not be for which attempt was made to catheterize the patient, but could not be done. So SPC was done in an emergency. Post SPC, 1400 ml of clear urine was drained. He was diagnosed with pelvic fracture associated along with right lateral malleoli fracture. In pelvic fracture, he had bilateral superior and inferior pubic rami and right L of sacrum fracture. He was advised abdominal binder and bed rest for the pelvic fracture, and right lower limb fracture open surgical intervention was done within a fortnight of trauma. He was discharged on SPC post surgery. No other intervention other than SPC was done for urethral trauma. At present, he is on SPC. Post accident, he has never passed urine per urethral. He denies any history of bleeding or discharge per urethra, any bowel disorder or incontinence, any problem in walking and sitting, any pain, abdomen, pyuria, or fever. In general physical examination, he is averagely built and fairly nourished with a BMI of 21 kg per meter square. He is conscious oriented to time, place, and person. He is afebrile with a pulse rate of 78 per minute in right radial artery, which is regular with a normal volume. His blood pressure is 116 systolic and 80
I think Sankit
116 by
can
80
pause in
millimeter of mercury.
between. Sankit, I think you can pause in between if the chairperson expert want to ask any question to the third year. Uh, they can intervene in
Sir.
between. It's like an exam for your final third year MBBS exit exam, MCH exit
Right,
exam.
sir.
Okay, so what else would you like to know? On one side is Samkit and on the other side is Harshdeep.
Yes, sir.
Harsh
Yes,
is
sir.
Harshdeep. Okay. So Harshdeep, what else would you like to know?
Sir, in the history part, we have covered that patient is having inability and of the passing urine. So
No, no,
most
no.
probably
You
suffering
just,
from.
my question is very brief. What else would you like to know? So
Sir,
don't tell what has already been covered. No.
okay, sir, I like to know if he is having a normal erections or not. If he is having normal morning erections or not at present.
Yes. What else would you like to know?
Sir, I'll more like to know about the mechanism of the injury as well, as the patient is having
Mechanism
any.
of injury, he has told you that there was a tree that fell on him and he fractured his superior inferior pubic rami on both the sides and right scala of the sacrum and right lateral malleolus. Okay. So mechanism of injury he has told you, severity of injury also he has indicated, and all the fractures also he has described.
Now the history, I'll ask him about the any gait disturbances, if any gait disturbances are present in the patient.
Yes, that is relevant. Why is that relevant?
Because for such patients, sir, we need to know during the surgery, if patient underwent surgery, we could have we have a possibility of doing the pubectomy for such patients who are already on gait disturbances. So pubectomy, if done in extensive way, can lead to the exaggeration of these gait disturbances.
Pubectomy can lead to an exaggeration of gait disturbance. How much of the role is pubic playing in the stability of the pelvis?
Sir, no, not the part of the if hello,
Have you,
sir, if
you must have seen a number of patients who have undergone either inferior pubectomy or complete pubectomy. How many of them develop gait disturbance?
not for the inferior partial pubectomies, but if the patient has to undergo, if there is an extensive injury and we have to go through the transpubic route, then
Yes.
there are chances of increase.
If transpubic is done, how many patients will develop gait instability?
I don't know exact number, but probably the if usually we do a less extensive
Yes.
pubectomy, just covering the pubic
Okay,
part. So gait disturbances
what
are
else
not so
is the
common.
importance of asking regarding gait instability?
So to get a baseline that the gait disturbances are due to the pelvic fracture itself, rather than we have post surgery we have induced the gait disturbance in the patient.
Okay, that is one. And number two, it's more important is for the timing of the surgery. Because if the patient is still in the recovery phase, you look at his number of fractures he has had really. Do you know about the classification of fracture pelvis?
Yes, sir, pelvic fractures can be classified on the basis of tiles classification.
Yes. What is Tiles classification? And
So
what are
in
the other
tiles
classifications?
yes, sir.
Are there other classifications also?
Sir, there are classifications, but I have just know about the tiles classification at present.
Okay. Talk about Tiles classification.
And tiles classification, it is based on the presence of the posterior arch of the pelvis, in which type A, B, and C classifications have been done. In type A classification, there is the posterior arch of the pelvis is intact, so there is no neither horizontal or vertical instability in the patient is there. In type B, the fracture is leading to the horizontal rotational instability is present, but the vertical stability is maintained. Whereas in type C classification, type C of the tiles classification, both the horizontal, the fracture in the posterior arch leads to both rotational as well as the vertical instability of the patient, of the rotation, leading to the increased chances of the urethral disruption.
So you see in the classification is a posterior arch fracture that is important.
Yes.
The pubic bone, even if it is in what type of pubic bone injury will there be a urethral distraction?
So in bone, pubic rami fractures, there will be distraction only.
If there is a fracture of the either the superior ramus or the inferior ramus, will there be a urethral disruption?
No, sir.
So at least there has to be a fracture of both the superior and inferior, and maybe if bilateral, that is the situation where there would be a disruption. But in posterior arch, what can be the various mechanisms of fracture pelvis? What type of an injury leads to a fracture pelvis? How does it actually? How does the pelvis get fractured?
Sir, in pelvis, can get fracture due to the direct trauma, that is due to the direct fracture in which there will be the anteroposterior axis of the pelvis will get compressed. Other is the rotational trauma due to the torque, in which there would be an open book type of the pelvic fracture could be there. Hello.
Hello, yeah.
Hello.
You are audible.
Sir.
I think Amresh sir is not audible. Rajiv TV sir, if you want to continue with further questions, I think.
See, in this case, they have put only an SPC. What does this mean? There was no other intervention from the orthopedic people. What does it suggest? It gives you an indication about the type of the
It
injury.
suggests that it would have been a stable fracture only, which did not need any open intervention or the displacement of the bony fractures. So the most likely the injury would have been managed by conservative management. So it would not have been an unstable fracture.
So from the history, it gives you a clear-cut suggestion that this is a stable fracture. Maybe only one of the rami is fractured and there is not much of distraction. When you will say that this fracture is quite unstable, what is the indication on an X-ray? Because after when the patient comes, they will take an X-ray. So what indicates that the patient is having an unstable pelvic fracture? One indication.
So the pubic diastasis, if we see pubic diastasis on the first go in the first X-ray, then we'll consider that as an unstable fracture, as an open book fracture. So we'll manage that patient accordingly with the pelvic binder. Then urethral injury would be our less prior concern. Then we'll be mainly managing the patient, taking hemodynamic control, managing that pelvic fracture with binders or if needed, surgical intervention.
One indication is that when there is distraction of the sacroiliac joint, then there is no other way than for the orthopedic surgeon to fix the thing. That is the only indication which says that this fracture is quite unstable and immediate intervention from the orthopedic surgeon is mandatory. All other things can be some way or other managed conservatively. But nowadays, even in other fractures, even if there is a pubic rami fracture or anything, the orthopedic people tries to fix up the injury fracture. Now, with these indications, now what are already the general physical examination findings are given. What more you want to know? Because already Samit has highlighted. Any more thing to highlight, Samit, in the general physical examination? Samit, can you hear me?
Yes, sir.
Any more thing you want to highlight in the general physical examination?
In general physical examination, sir, oral cavity and dentation is normal, sir. SPC is present with skin around it appears normal. Clear urine in the bag. Spine is normal. There is well-healed scar of previous orthopedic surgery present in right lower limb, and the gait of the patient, it is not.
Okay. As a urologic surgeon, what is one important thing you will notice or you'll note when you do a physical examination, general physical examination, which is very important for you in the management?
Sir, I'll notice that that's site of the SPC which has been placed.
Yes. Why it is important?
So first off, because it is important for us during the time of surgery when we'll be assessing the posterior urethra via Haigru's dilator. Then the site of the SPC will be holding the utmost important to guide our access through the posterior urethra to the better neck. So SPC site should be preferably in the midline around 2 finger breadths above the pubic symphysis.
I am also requesting Dr. Priyadarshini sir and Dr. Ansari sir to join in the expert panel, as Dr. Amresh sir is not there and Uttamita sir is also probably I'm not able to connect him. So they can also be the part of the expert and ask question if required.
This is very much important because when you are called into an emergency to do a suprapubic cystostomy, it should be minimum 2 centimeter above the symphysis pubis in the midline. Why? Because during your main management, you will have to do a Bouguer or you will have to pass a flexible cystoscopy so that you can very well, the angulation will be better to go into the prostatic urethra, bladder neck and prostatic urethra. Anything more you want to know from the general physical examination?
I've talked about the gait. Then in general examination, I'll also assess the patient if since patient was able to sit, I'll assess the patient if he can be taken to the lithotomy position for the surgery. So if
Okay, when the patient is coming into your examination room, walking with a normal gait, you can be pretty sure that the patient is will be able to place in the lithotomy position. Another thing in the history, you have said that the patient needs, you want to take history of erectile dysfunction is very much important, especially in a young individual. So will you like to assess and what are the questionnaires you put to the patient in order to see that he's having a perfect, there is no erectile dysfunction problem with the patient?
sir, I'll ask the patient if he is having normal morning erections as well. Since the patient is unmarried, I'll ask if he is having any active sexual partner to whom he is having regular intercourse and if he is satisfied with those courses as well. So I can plan for IEF questionnaire also, sir, and grade him if he is having any erectile dysfunction of that kind.
As a urologist, is it mandatory to do an assessment for the ED in these patients with pelvic fracture urethral distraction defect?
Sir, we have few questions in the chat box from the residents. One is regarding the position of the SPC. One is regarding the role of DRE and position of the prostate. So
Yeah.
just sharing those questions. And also we have 15 minutes time we are left with. So right.
Okay. Okay. So will you see when you do a digital rectal examination in this patient, because it is not highlighted in this general physical examination? Is it important?
Yes, sir, in digital rectal examination, we'll be examining if in digital examination, currently patient is having no complaint at the present. But when the patient comes in the emergency, in the post traumatic period, we get a digital rectal examination to examine for any laceration is there, that concomitant involvement of rectal injury or high riding prostate due to the disruption of the prostate. But at 3 or 4 months later period, it is usually seen that the high riding prostate usually comes to the normal level due to the resolution of hematoma and the stabilization of the scar.
Okay. Shivam, do you want to ask?
Yeah. Thank you, Dr. Raji. So definitely there is no harm in doing a digital rectal examination, even if it comes after 3 months. You may get certain surprising findings also, right? Sometimes the patient may have had a rectal injury during that period. Sometimes you can feel the bony spicules also. So there is definitely, and it depends upon how old the patient is. And suppose the patient is slightly older, you need to assess the prostate also. So when we are talking about erectile dysfunction, Harshdev,
Yes, sir.
if suppose this patient develops erectile dysfunction after the injury, would it change your management?
Sir, if the patient is having erectile dysfunction post-injury, then I would be suspecting as it to be a primary erectile dysfunction after the PFUI. So I'll first plan for the penile Doppler, sir, to document the vascularity if there has been any damage to the internal pudendal arteries or the penile arteries, to document that if they need revascularization. So if it comes out to be deficient, so I will plan for penile revascularization prior to the urethroplasty surgery.
Okay. So you would do a penile revascularization if the penile Doppler study shows some kind of reduced vascularity. Is it what you want to say?
If there is complete absence of the flow in these in the bulbar arteries, the internal pudendal and the bulbar arteries, then I'll plan for penile revascularization, sir.
So again, a Doppler study is not a confirmatory study to know exactly if there is a injury to the penile artery or the artery which is supplying the penis. So if there is, because a lot of factors would can cause a change in the Doppler study. So even anxiety may produce a reduced vascularity. If there's a patient has a generalized atherosclerosis, it can also produce a decreased vascularity. So you must know exactly if there is a localized block which is resulting in the loss of erectile dysfunction, right? So that can only be done by an angiography. It's
Yes.
it's temporary. Doppler study will not say, right? So yes, there is an option that yes, if you find there is a localized block and that is causing erectile dysfunction, then probably there is an option that you might do a revascularization before doing erythroplasty. But suppose if the everything is normal, the vascularity is normal, but still the patient has erectile dysfunction. Is it possible?
Yes, sir, it is possible because then we will not consider it to be a vascular cause. Patients with post PFPI, they also have a neurogenic cause of the erectile dysfunction seen in around 70% of the patients.
Exactly. So it could be neurogenic also, which can actually be dealt with by what kind of medication? Do they respond to PDE5 inhibitors always, or
Yes,
which would be the best kind of treatment in these patients?
So they since the vascularity is maintained, so they'll respond to the PDE5 inhibitors.
So
For such
PDE5
patient, we can
inhibitors
give a
not
first trial.
necessarily. Yeah, so not necessarily. So ideally, if the PDE5 inhibitors are not helping them, then intracavernosal injection would
Injections.
very well help them in
Yeah.
neurogenic cases of erectile dysfunction. Right? Okay.
Yes, yes. The
Go
first
ahead,
trial will
Dr.
give
Raj.
a PDF inhibitor. Yes.
Right. Sure.
Sorry,
Go
I just
ahead.
want to I just want to interrupt. So we have only 10 minutes time left.
Yeah,
So we
understood.
can.
So we are hurrying it up.
Go ahead.
What further evaluation will you require in this patient? Physical examination. How will you proceed with this patient further?
So after the physical examination, general physical examination, I'll get to the abdominal examination, then the general systemic examinations. If all of them come out to be normal, then I'll plan the first yes, basic blood investigations with urine routine and culture for such patient. And following
Okay.
that, then I'll get a dye study with a retrograde urethogram and voiding cystourethrogram for this patient, sir, to delineate the length or the level of the stricture as well as the degree and the severity of the stricture.
That means you want to do apart after getting the urine culture and the routine blood evaluation, you want to go ahead with a combined urethrogram. That means a
Yes, sir.
retrograde. If you are called to the suit to do this procedure, to do a
Yes.
combined urethrogram, which procedure you are going to do first?
Sir, I'll get a retrograde urethogram first, sir.
What is the advantage of getting the retrograde urethrogram first?
So we'll delineate the level of the distal end of the stricture, and we will know that if the stricture pattern is completely obliterative or there is a partially obliterative stricture. So if in that case the dye would be going into the bladder. But if we would have done the micturating cystourethrogram first, then the dye would already be present in the bladder, so we won't get the idea of getting the dye into the bladder in the first.
Okay, first of all, when you do, you have to have a scout film because that gives you an assessment about the bony
Yes,
alignment and other things before you put in the contrast, place the patient in the appropriate position and contrast. Is there any role of MRI in these patients with a posterior urethral distraction defect? What is your opinion?
Sir, first of all, for such patients, the MRI plays a good role in the distraction injuries because it can delineate the relationship of the distraction defect of the posterior urethra with the rectum as well as to the pubis, pubic symphysis, and it can also show the differences in the alignment. But one thing we need to be sure of. Hello? The one thing we need to be very alarming about that such patients usually have undergone orthopedic intervention, not in this case, but usually in the case they could have had metallic implants in them. For those patients, we would not be able to do those MRI. But in a complex PFUIs in which we need to get an idea of the alignment and the relationship with the rectum or the pubic symphysis, we could go with MRI investigations if we are finding RGMCU to be not up to the mark.
Whether a MRI alone is sufficient enough, or when you do an MRI, it should be combined with a combined ureterogram?
So in MRI, we just need to inflate the urethra with the saline or the jelly to just distend the. So at time of MRI, we don't need the contrast studies at concurrently, concomitantly.
So the role of MRI is basically when there is a complex injury, number one.
Yes.
Number two, MRI alone is not sufficient. MRI should always be combined with a RGU MCU. Now over to you, Seth sir, for your question is.
Can I just come
There's
in
one
here?
question in the chat box regarding gapometry, so you can highlight this question.
Shivam, go ahead.
Yeah. So when we talk about PFUDD, then the question of obliterative, non-obliterative stricture doesn't arise, Harshdev. PFUDD is a distraction defect, right? So there's nothing called a non-obliterative PFUDD. So the best way to do is a dynamic combined MCU RGU, where you would be able to know the exact length of the stricture also. So when you do this kind of a study, the best would be a dynamic combined film, right? Okay, thank you. Dr. Amlesh can come in, please.
Yes, I'm sorry if I got disconnected. I'll not take much time. I'll just tell the students that the exam can go in any direction. You see, there have been 3 examiners and each person has emphasized on a different thing. So some, like I was more emphasizing on the emergency situation and what was so you can see, so whenever you see a case and whenever you are preparing for a case, you should think in what all directions can the exam go. Like for this case, the exam could go in the direction of management of the acute trauma, the orthopedic aspects also, and then how do you follow up, how do you investigate, and then finally how do you manage. And even in terms of surgery, there are a number of nuances that could have been asked and that will be asked in the exam. So whenever you're preparing for a case, first, before you start reading, first sit down and think in what all directions can the exam go, and then accordingly take out the literature and read accordingly. One small point that I also wanted to make is regarding this gentle catheterization. Although it is mentioned in all the books that a gentle attempt should be made at catheterization to see whether it is partial, and then if it is partial, then if the catheter goes. But I can tell you 100% certainly there is nothing like gentle in catheterization. In catheterization, with even if you are extremely careful, your risk of converting a partial into a major disruption is high. And this is something which I tell my residents not to do it. But if you say that in the exam, I will not fail you because it is mentioned in the book. But as a practical suggestion to all the residents who are here, I would say please do not attempt any catheterization. If you know there is a fracture pelvis, if you know there is blood at the meatus, it is almost 100% certain that there is a major urethral injury. Please do not complicate it further by further attempts at catheterization. If the bladder is palpable, very well and good, you can do an SPC. If bladder is not palpable, wait till it becomes palpable or till the investigations show that there is a disruption of the bladder or of the rupture of the bladder. If there is a rupture of the bladder, in any case, the patient has to be operated. And if the bladder is not palpable and with time it is going to get palpable, then you have to wait. Please do not complicate the already disrupted urethra further. Okay, thank you very much.
I would just like to add here about what Dr. Said said. Yes, when the patient comes in emergency, definitely there is an option that you can do a gravity urethrogram to know the type of injury. Though most of majority of us are not doing it, but then definitely the guidelines do say that you can do. Secondly, not putting a gentle catheter, but doing a flexible cystoscopy is one of the where one of the guidelines say that if you want to just know exactly that there may be just a minor injury and you can pass a catheter, just pass a flexible cystoscope. Try to see if there can see the lumen, you can pass a guide wire and pass a catheter over it if it is a minor type 1 or type 2 injury. Otherwise, yes, I agree. Most of the cases we would do a suprapubic cystostomy and later do a definitive surgery. Yes.
Now,
So
Samit, can
go
you,
ahead with the type. Yes, treatment. Yes, go ahead.
Samit, can you highlight post what are the investigations done, combined urethrogram and other things?
Sir.
So we can maximum extend for another 5 minutes. So already
Okay.
we are
Just
over.
quickly,
So
yeah.
5 minutes.
This is the retrograde urethrogram. Do you have the combined 1, 2?
MCU,
Yes,
please.
sir.
Yeah. Yes. What do you see on her slip? What do you see and what? Yeah.
So this is a supine X-ray film taken on the time of MCU, most probably time of the bladder filling. I could see a distended bladder with smooth outline. Currently, with having a right-sided grade 2 VUR and left-sided grade 1 VUR as well, with echoelectric reflux as well.
Anything else? Anything else? So MCU, is it a MCU film?
Or this cystogram or the MCU?
So this is not a cystogram. This is a filling.
Filling phase.
All right. So the patient has not been able to void, right?
Able to void, yes. Yes, sir.
Right. So what do you think? Um, uh, should something should have been done so that the patient would be probably able to void, because we want a maturating film, right?
So we could have given the patient an alpha blocker so that the bladder neck could have been opened, and then we would have advised the patient to get an MCU done. That it would have helped the patient to void and delineate the defect in the posterior urethra, the proximal aspect of the defect.
Okay.
So Harshdeep, can I?
Yes.
Sorry, I just wanted to ask Harshdeep,
Yes,
what are the other points in the radio in this X-ray that you can see in this film? Because you have described the bladder shape, you have described the VUR, you have on the right side, left side, but there are other also important findings also which you should point out. What are those important findings? Number one, you should describe the fractures that you can see and whether the callus is formed or not. And another very important point you should point out is the position of the bladder. Can you see the position of the bladder? Is it usual? Is it common?
So it's a slightly higher.
It is significantly higher up compared to what you would. Yeah, significantly higher up compared to what you would see in most of these situations.
So I think due to my screen, I could not delineate the fractures because they are going outside my screen. Sorry.
Yes, they are going outside, but yes, on the right side you can still see. Yes, if you are not seeing, you should point it out. That I would like to see this part also because I would like to assess the fractures.
I think there is a significant displacement of the rami. Samit, do you have another picture showing? Yeah.
I think we have only last 2-3 minutes. Just 2 minutes of management can be done, maybe. What?
So you can
what
say
could you
that
do?
Since I was not able to assess the posterior urethra in this patient, now I'll plan for an antegrade scopy with a flexible scopy to assess the bladder neck and the posterior urethra. And once I am sure of the defect of the length, then I'll plan for the patient for the progressive perineal urethroplasty.
This antegrade urethroskopy, are you going to do on table or as a pre-operative evaluation?
Sir, would you do an antegrade? Yeah. Or retrograde also?
So I'll get an antegrade scopy before the taking patient for the surgery as well, because this will help me delineate the amount of the complex injury is there. if I'll not do that in a single setting. Sir. We'll get it first in a pre-operative setting, and then I'll plan for surgery after getting a due consent of the patient and explaining the amount of the degree of the severity of the injury he's having.
Usually we do it on table when you have planned for the procedure. We have even though the combined ureterogram is done prior, we will do a proper assessment on the table when the patient is in anesthesia. Then we will go ahead, we will plan up the procedure. What about it, Dr. Seth, sir? Your opinion on this?
Harshdeep, what are the difficulties that you would anticipate in this particular individual patient compared to other cases of PFUI or PFUDD? In this particular patient, you look at this X-ray and tell what are the additional problems that you can anticipate.
In this patient, first of all, I'll be anticipating that the part of the defects length would be long because the bladder is significantly on the higher level.
Number two.
And second would be the fracture segment is also involving the left of the pubic rami. So it will be a difficult case because the distraction injury will not be aligned. The posterior urethra and the anterior urethra must not be aligned. They would be having some sort of any distraction.
Number three. Can you see something which is glaring at you, which you normally don't see in these cases? On the left side, can you see something?
Yeah.
Can you see any opacification?
There is an operator from it. We could see a radiopacity of callus that have occurred post injury. So removing that callus would also be.
Yes, the amount of callus formation in this patient is much more than what you see in most cases. So it must have been a really bad fracture, and being a young patient, he has formed a very big callus. So you may actually have to excise all this callus, and this excision of this huge callus is not going to be that easy.
Yes.
Okay.
What you,
Dr. Shivam and Dr. TP.
Yeah, Dr. Sureka, do we have time? Yes, okay.
So we should wrap
Okay,
up,
Harshit.
sir. We should, yeah, maybe last question, sir.
So if you want to give the patient the best results, right? So what are the things that you would be very careful while during surgery, Harshit, please? Because the first chance is the best chance for the patient, right? Harshit, are you there?
Yes, sir. I'll be first of all, since the patient is having severe trauma in the pelvic, so I'll doing the dissection very meticulously, sir. Because since the blood supply from the antegrade aspect is already, so I'll be doing dissection to prevent as much as of the retrograde supply, so that the chances of getting a bulbar urethral ischemic long segment stenosis is less. Other factors, while getting to dissection through the perineal body, I'll try to preserve, if possible, the bulbar arteries. One of the bulbar arteries, if it could get preserved, but it's like looking difficult in such cases. But I'll try to preserve the vascularity of the bulbar artery if possible during the dissection, sir. And the third, hello.
Yes, go ahead. Go ahead.
Go ahead.
And the third is that for such patient, I'll try to remove as much callus as possible till the level of the I'll get a good bleeding posterior urethra for the anastomosis, because the chances of getting again complete stricture stenosis is more as when the residual callus is being left behind.
Right. So the most important thing is, like, if you're doing a PFUDD repair, not preserving the bulbar would be a very difficult thing. Usually you would not be able to. So the best thing is, yes, you need to get a very good exposure. And most of these patients would require a wide inferior pubectomy, right? So to get the proximal urethra. And you need to do a proper mucosa to mucosa anastomosis. If you are not able to see the proximal urethra properly and you have not a good exposure, you would not be able to place proper sutures. So make sure that you have a very good exposure, wide exposure. You have a very good proximal urethra with good protruding mucosa, which you can see the healthy mucosa. And then only you need to repair this. So that will dictate, or that will decide your results. So give the best possible result to the patient by doing a good, proper mucosa to mucosa anastomosis. Right.
Continuing on what Dr. Shivam has said, Harshdeep, I'll tell you the practical answer in the exam is you can tell, sir, this is too difficult a case. I would like to refer to somebody else, someone who's more experienced. Yeah, it's
Right.
actually because the examiner also wants to know whether the candidate understands his capabilities and his limitations.
Limitations, yes.
Limitations, that is also an important thing. So if you can say this, sir, this is too difficult a case, I would not like to do it. I would like to refer this patient to somebody who's more experienced, because this is actually a very difficult case. And if you can realize and understand the difficulties, that is also a point in your favor in the exam.
Yes, I perfectly agree with Dr. Said, what he's saying. Perfect.
So
I
thank
think,
you all
I think-
expert, and thank you the presenters. So
Thank you,
we'd
sir.
like we should finish it
Can I
off.
say something? Sanjay, can I say
Yes,
something? Just a word.
yes, sir.
Just a request for the chairperson of this program, Dr. Amlesh and Dr. Rajiv TP, as well as Dr. Shivam. Please evaluate both the candidates, and we would like to keep evaluating them. And probably at the end, in the final conference, we would like to felicitate at least number one and two. So, because it is a case presentation, so this would have a separate um, um, award. So please, Harshdeep and Samkit may please be evaluated by all three, sir. And this may be sent to Dr. Rishi Nair.
Thank you. So I would just suggest that Dr. P.P. Rishi to give a kind of criteria for evaluation beforehand to the
Yeah.
judges also.
We-
So
we-
that it can be done in a more professional manner, right?
Absolutely very well taken, sir. Because this was the first one we are doing. So we will obviously make a criteria of evaluation and forward it to the examiners or the chairperson in advance. Extremely sorry for this time because we did not think about it. It's a very good input. We will follow it.
Surely, sir. Let's move ahead.
Thank you. Thank you. Thank you very much.
So I would like to thank all the participants for the case, and as well as expert for taking their times and helping each and everyone to learn from the case. So we'll now proceed to the next session, which is journal club. We have two journals. So the first is uh, Da Bla CA, which is a study which is published in Journal of Oncology on oncological outcome of short-term intensive chemoresection with mitomycin. And I would like to invite the expert for this session is Dr. Gautam Ram Chaudhary, Dr. Ankur Mittal, and Dr. Ganesh Bakshi. Dr. Ganesh Bakshi, I was trying to connect him. He probably has joined, though I'm not sure. Uh, and the case will the journal will be presented by Dr. Sumit Mandal from SGPGI, and the resident from the AIMS who will participate to interact with Dr. Sumit would be Dr. Keshav, Dr. Anurag, and Dr. Lavkesh from AIMS New Delhi. So I'd like to request Dr. Navneet ji to allow them to join and open their mic. Shumit, are you there? Can you share the?
Yes, sir. Yes, sir.
Your,
Yes, sir.
yeah.
So, good morning, everyone. Today, my journal club is Da Blaka 13th study. So, it is one oncological outcome of short-term intensive chemoresection with mitomycin in non-muscle invasive bladder cancer. Primary outcome of a randomized controlled trial. It was published in Journal of Clinical Oncology initially in October 2022, and then they came with an erratum in January 2023 also. The Journal of Clinical Oncology is basically a journal which is run by American Society of Clinical Oncology (ASCO), And the primary author, Maria Limrin, is a person who is basically has published other articles also with regard to mitomycin in bladder cancer. So as we know, this non-muscle invasive bladder cancer requires an extensive follow-up and repeated treatment because of its high recurrence rate. So different various treatment strategies that we have for TURBT, for non-muscle invasive bladder cancer, TURBT, office fulguration, active surveillance, and the latest kid in the block is the chemoresection. So chemoresection is short-term intensive chemoresection with mitomycin C, which has been investigated as a non-surgical treatment to lower the patient discomfort and to decrease the cost of treatment. And currently, it is more like an experimental with only a few studies, and complete response rate that has been studied that has been reported are ranging from 37 to 50% in intermediate risk TA NMIBC. So the aim was to evaluate the number of patients in need of a procedure and long-term oncological outcome after short-term intensive chemoresection with mitomycin C compared with standard treatment and adjuvant installation in recurrent setting. The key objective being, can we avoid surgical procedure in recurrent NMIBC? And the hypothesis that they formulated and tested was the long-term effect of chemoresection would result in a reduced number of TURBTs performed over 2-year period basis on the basis of evidence of TURBT in patients with complete chemoresection at baseline. And chemoresection could also result in a recurrence rate which is not significantly different from TURBT and standard adjuvant installation. So in methodology, it was an open label randomized control trial which was done from January 2018 to August 2021. And it was performed in 2 major urological centers in Denmark. So that is why the name comes from DABLACA, Danish Bladder Cancer 13. The patients who were included were TA low-grade and TA high-grade NMIBC with recurrence of more than one tumor, thus qualifying for intermediate or high risk. Papillary tumors with diameter of up to 2 cm and no upper size limit for flat lesions. Those patients who were excluded were BCG treatment within the past 2
I'm
years.
interrupting. Sumit, I'm just interrupting.
Yes, sir.
Keshav and Dr. Lavkesh, you can open your mic and you can ask any question in between or interact with Dr. Sumit. And our expert can also interact with Dr. Sumit and the other two residents.
So Dr. Keshav and Dr. Anurag, do you have any questions or anything right now? Whatever has been, you can interact in between in General Club. See,
Yes,
General Club is not a seminar. We should understand it. It's not a seminar on a topic. More to learn from a General Club. So just you need to interact in between whenever you feel like. Okay, Sumit, please proceed.
Sure,
Yes,
sir.
yes, sir. So the I've already
I'm
told
also
about the inclusion
requesting Dr.
criteria.
Apul Goel to join as an expert because I'm not able to. I'm not able to find Dr. Ganesh Bakshi in the online. Right.
So patients who were excluded were BCG treatment within the last 2 years, previous treatment with mitomycin C except single shot, and suspicion of carcinoma in situ or invasive and solid tumors, incontinence, acute cystitis, pregnancy, or breastfeeding patients. The randomization was done with the REDCap software in a 1:1 ratio into an intervention and control group with allocation concealment. So in the intervention group, 40 milligram of intravesical mitomycin C was administered 3 times per week for 2 weeks with 2-hour dwell time before voiding, and followed by which they underwent a flexible cystoscopy 4 to 6 weeks after the final installation. And in the control group, the standard care was maintained where TURBT or biopsy with tumor fulguration was done, followed by adjuvant intravesical mitomycin C for low grade or intravesical BCG for high grade TA once per week for 6 weeks, the induction course only, followed by flexible cystoscopy 4 to 6 weeks after final installation. Throughout this procedure, no food or fluid intake after midnight was recommended and was followed. Complete emptying of the bladder was secured by catheter before installation both the groups. No perioperative or maintenance installation were used in either group. And majority of the cystoscopies, both outpatient as well as TURBTs, were performed in both white light and narrowband imaging. After the flexible cystoscopy done after 4 to 6 weeks after final installation, response was evaluated. If they had complete response, a second cystoscopy was done after 4 weeks. And with the tumor remnant, biopsy was done or a TURBT was done. Depending on the histopathology, if it was a benign pathology, they underwent for a surveillance protocol. And if there was a urothelial tumor, labeling as incomplete response, they underwent some adjuvant intravesical BCG for high-grade tumors.
Sumit, there is a question on the chat
Yes,
box.
sir.
How was the size of the tumor recurrence confirmed either by diagnostic CP or by CT scan. So one question is from the.
They have not mentioned about any CT scan or ultrasound in the follow-up time. What they have done is only done cystoscopy. The follow-up was mainly based on cystoscopy.
So the recurrence was confirmed by
Cystoscopy.
cystoscopy, the
Yes.
size of the tumor and all.
Yes, sir, yes. Sir.
So have they mentioned that whenever there is a recurrence based on flexible cysto, have they mentioned the details of those lesions in the article?
Yes,
Regarding
yes,
the
sir. They have
size?
mentioned with the size and they have mentioned about the number also. I will come to that in the result section.
Okay, go ahead.
The primary outcome that they studied was the number of patients undergoing a procedure, either TURBT or office biopsy and tumor fulguration within the first 2 years after random assignment. And the secondary outcome that they studied were recurrence-free survival and serious adverse events based on CT scan. Power calculation was done based on using the comparison of two proportions where they presumed equal recurrence of 50%
Can
in
you
both the
please go a
groups.
bit slowly, please? Can you please go a bit
Yes, yes,
slowly?
yes. Sure, sure. So power calculation was done based on
Dr.
comparison of
Sumit,
two
I have a
proportions.
query.
Yes, yes, please.
Dr. Ganesh
Yes, what was
Bakshi is
the
there who can join as an expert. So kindly unmute the Dr. Ganesh Bakshi. The host, Norjon, can unmute.
I have
the Dr.
joined, don't worry. I was just wondering.
Dr. Sumit, what was the
Can ask
frequency of
question.
follow-up cystoscopy in both the groups? How
So
frequently
they
did they
followed.
perform?
Yes, sir. They followed the Danish guidelines. In Danish guidelines, what they do is they do cystoscopy in 4 to 6 weeks interval, and then eventually, as we do in intermediate group, after 3 months and after 6 months. So the initial cystoscopy was done by the primary physician, Ms. Lindgren, and then subsequently they were followed up in their own hospitals.
And the same person who did the initial cystoscopy while randomization, did they perform the surgery itself? Or was it a different set of surgery?
That they have not mentioned. Who has done the surgery, that they have not mentioned.
I mean, recruitment and surgery were done by the same person.
Who has done the TURBT has not been clearly mentioned, sir. But who has done the first cystoscopy to look for the recurrence was mentioned.
No, it's for the recruitment. What's there is it's been conducted in 2 different centers. So the person conducting the trial, the surgery was performed at 2 different centers. Initial cystoscopy, the first cystoscopy after whether the chemoablation or the resection was performed by this person who was not blinded to the results. And the subsequent cystoscopies were conducted at the respective centers itself. It was not performed by the same person only.
Not performed by the same person.
Yes.
How was the allocation done, Sumit?
So the allocation was done by randomization, sir. They used a RedCap software and they allocated in intervention group and control group in 1:1 ratio. Sir.
Okay. So all these questions are very important in general, like, analyzing this, the material and methods is very important. We need to see it.
Yes, sir.
See whether randomization done was proper or not, what type of study it is, what is the allocation technique, it is snooze or something else they are using. So we need to focus. I think that's why we are asking these questions in general club, that these are also important things we need to take care. Go ahead.
For power calculation, they used a comparison of 2 proportions and they presumed equal recurrence rate of 50% in both the groups and presumed a complete tumor response of 50% in the intervention group. And on the basis of that, a primary endpoint difference of 25%, which is 50% of 50% between the groups were presumed. And a type 1 error of 5% was taken and statistical power of 95% was taken, based on which 54 patients were calculated in each group. And expecting a 10% dropout, they increased the sample size to 120, which was the final N value. For statistical analysis, treatment response was shown by proportions and categorical data were shown by chi-square Fisher exact test. A multivariate logistic regression analysis was performed to evaluate the relationship between the treatment effect and variables detected in the univariate analysis with P of less than 0.1. And the results were listed with 95% confidence intervals and medians with interquartile range. And the level of significance was set at 0.05. The number of patients in need of a procedure was compared between the groups with chi-square test. The recurrence-free survival was analyzed using Kaplan mirror method and tested by using log rank test, where the patients were censored at the time of death, progression, or end of follow. Recurrence at the first follow for both the groups and the number of recurrences for patients with or without a complete response to chemoresection were compared using chi-square test. And adverse events were analyzed using chi-square or Fisher exact and differences expressed in percentage. Coming to results. So initially 357 patients were assessed for eligibility, out of which after exclusion because of various reasons, 120 patients were randomly assigned, with 59 patients in the intervention group and 61 patients in the standard group. One patient in the intervention group did not receive the allocated intervention, hence he was finally excluded. Because none of the patients lost to follow-up, in the final analysis, 58 patients were included from the intervention group and 61 patients were included in the standard group for final analysis. Regarding the baseline patient characteristics, the age of the patients were pretty much matched, 70 and 72. Males were also almost equally distributed, 75% and 68%. Regarding number of tumors, they had not taken one tumor, they had taken more than one tumor. So starting from 2 to 7, 77% in the control group and 85% in the intervention group. And when more than 8 tumors were present, when noted, it was seen that in the control group they had 23% of them, and in the intervention group in 14%. And this was later pointed out in one of the later two editors also, which I will come to subsequently. Regarding tumor size, less than 5 millimeter tumors were equally distributed, as were more than 5 millimeter sized. High-grade tumors were around 30% in both the limbs, and previous BCG treatment was present in about 10% in both the limbs. The median recurrences were 1 in control group and 3 in intervention group. The median follow-up period was 34 months, and 4 patients died of non-bladder cancer-related causes. And after 14 months of follow-up, 1 patient progressed and underwent cystectomy, who ultimately turned out T3, and another patient discontinued treatment and follow-up and because of comorbidity.
Sumit, may I interrupt you?
Sumit, I would like to clarify one thing.
Yes, sir.
Can you go a bit slow? You are a bit fast. Go a bit slow.
In the previous baseline patient characteristics, you told one of the exclusion criteria was previous BCG treatment. So when they have mentioned this previous BCG treatment, is it more than 2 years from the last resection? Because
yes.
Okay.
Because more than up to 2 years of BCG, they have excluded. That's why. So moving forward.
Okay.
Significantly fewer patients in intervention group than in the control group required a procedure during the 2 years of follow-up. In other words, number of patients avoiding any procedure in the intervention group was 17, who entirely avoided the procedure, whereas because of the design, none of the patients in the control group. By calculation, so the mean number of procedures was reduced by 0.5 procedures per patient, from 2.1 procedure to 1.6 procedure in the control and intervention group respectively. And because the number of procedures reduced in the intervention group, hence the need for subsequent TURBTs also came down. And it was in 26 patients in the intervention group and 47 patients in the control group, the difference being statistically significant. However, when they had a recurrence, subsequent recurrence, then there was not a significant difference between the intervention and control group with respect to all procedures taken together and TURBTs taken separately, 37 and 35 respectively, and 26 and 21 patients respectively. So in other words, the number of TURBTs had gone down, but not the number of recurrences, and number of procedures after recurrences also. In the 25 patients who underwent some kind of intervention, these are the patients who had incomplete response or no response, out of which they also saw there was a phase shift from TURBT to office procedures. In other words, the number of TURBTs came down and number of office procedures and tumor fulguration went up, and this difference was statistically significant also. For recurrence, regarding recurrence, initially they had published this data in the October 2022 journal, where they mentioned there was no statistically significant difference between the groups. But they received few queries based on that, because some numerical values did not match up, which is why they came up with an erratum in 2023 January. And there they published the recurrence data in low grade and high grade separately. Here we see with respect to number of recurrences, the pathology distribution, and the number of tumors at first recurrence. There was not a significant difference between intervention group and the control group when low grade and high grade were stratified separately and calculated separately. Moving on to the recurrence-free survivals, these are the Kaplan-Meier curves of the recurrence-free survival plotted against time. In the left side, we see the recurrence-free survival curve of the control group versus intervention group. And in the below table, they have comparison between the 12-month recurrence-free survival of 36% in the intervention group versus 43% in the control group. And this difference was with a p-value of 0.5. And this difference was also maintained at 24 months with a p-value of 0.15. When they compared the recurrence-free survival of low grade versus high grade, there also they found that there was not a significant difference with a p-value of 0.6. All these p-values had been calculated with log-rank tests. And recurrence at first follow-up, they found that intervention group, there were 16 patients who had recurrence in the first follow-up versus 13 patients in the control group, p-value being not significant. Therefore, the number of recurrences that happened was not different, as was the recurrence-free survival. However, in the intervention group, significantly fewer recurrences were observed among the responders than among the non-responders to chemoresection. So, number of recurrences in the responders were 11 and 5, with number of recurrences of 1 and more than 1, and in non-responders were 8 and 13. They tried to predict what are the factors that led to response and eventually translated other. So, in multivariate analysis, they found that the number of tumors, current smoking status, and previous number of recurrences were important factors which predicted tumor response in the intervention group. This was a data which they published in the 2020 article, but they subsequently in the 2022 article and the 2023 random, they did not publish this tumor response data. Moving on to adverse events, no grade 4 adverse events reported in either group. 3 grade 3 adverse events reported, 2 cases of cystitis and 1 case of fever in the control group. And dysuria, polycythemia, Palmer skin rash, cystitis, hematuria, and incontinence were seen less in the intervention group and more in the control group, with p-values being statistically significant. Moving on to the critical analysis, the strengths of the study were, this is the only study.
Here.
Yes, sir.
Sumit, I would
Yes, sir.
like that now the Keshav and Anurag can take up they can share their views about the critical appraisal of this. We have heard Sumit telling everything about the paper. Keshav and Anurag, can you just critically, do a critical appraisal of the topic which has been explained so far? How do you would like to do a critical appraisal of this journal?
So, sir, with respect to the critical appraisal, I feel that with respect to the strength of the study, definitely one thing is it's a randomized trial involving a significant number of patients they have calculated, and there was no loss to follow up in this. So they have taken 60 patients in each of the group, and for the number of procedures reduced, they have reached with a statistical power. And yes, they were indeed able to follow up the patients up to 2 years. So that I think is a good strength of this study, because hardly there's been a randomized trial with such a significant number of patients and such a long follow-up till now with respect to chemoablation as versus with prime TURBT in recurrent tumors. With respect to the limitation, I would consider including the high risk group, irrespective of the number, although there were 30% of the population included. I would still consider to make it a more heterogeneous, because they were ready to give BCG to these patients in order to avoid any recurrence. So comparing a mitomycin with BCG, such a heterogeneous group, the total parameters become different. And the previous studies till now have quoted its results only in intermediate type of patients. Second, therefore, I don't think so comparing a mitomycin with BCG. And that too, one more limitation that I have read this article is that they have never utilized any, apart from the 6 adjuvant doses of mitomycin, they have not given for the 2 years any other maintenance therapy. So this is not in accordance with any EUA guidelines with respect to intermediate risk as well as high risk that we need to perform, that we need to give maintenance therapy, although the schedule for mitomycin is not yet well established, but still, this is one of the limitation. Plus, the person performing the cystoscopy, as per the protocol that I have read, according to them, the person was unblinded. So he might would have been careful while performing the cystoscopies of the patients undergoing TURBT. There might be some variability, inter-observer variability with respect to this. Although the subsequent cystoscopies were performed at the respective centers, but still there is a limitation, because there has been no record whether the videos were compared by other experts also. So I think these are the few strengths and limitations that I could gather till now from the methodology and this.
So we are just overshooting it. Maybe we can just take comments from the chairpersons about this study and clinical applicability, and then move on. Dr. Ganesh and Dr. Ankur.
Ganesh sir? Okay, so as you rightly said, Keshav, so one thing is very important, the journal club, why we are presenting it, we should understand. The topic when we present on a journal club, first we should see what is the current literature which is available on this topic. We should understand what is the current standards, what we follow, and what in the guidelines. When we, as you said, the current standards are still with BCG and the other roles are coming up. So we have a recent meta-analysis on systemic review on this topic, which was published in 21 in a Turkish journal. There was a systemic review on this same topic, which have concluded that the chemoresection on mitomycin is have a less efficacy as compared to standard TURBTs, as well as with low complications, and to be used when only a patient is not a feasible candidate for surgery, that is TURBT, standard TURBT. When we understand these standards, then we come to the topic. Once we have heard the publication and the topic, starting very nicely, I think Sumit has started with the knowledge of the journal, which is very important. What we are presenting, what journal, what impact factor, who is the author, who is the editor. We should also know from the journal club with that. Material methods we have already discussed, whether they are appropriate or not. Stats we need to discuss whether they are appropriately applied or not. In this particular case, as we already discussed, the standards what we really think of in high-grade disease, we usually don't think of mitomycin as per se without hyperthermia or without, just using mitomycin probably stands as of now in the current standards without hyperthermia. So we have standard guidelines, we have BCG. So they have compared directly with the chemoresection with TURBT versus no TURBT in office procedures. If you see the primary objective, we need to really see it. Primary objective, they have taken into account that number of procedures. If I see what is more important when we talk about oncology, is the number of procedures or recurrence or progression? What is more important, Keshav?
It's the recurrence or progression for the patients.
Yeah, so whenever we plan a study, we need to think the primary oncological outcome should be the primary objective. Why they have kept the secondary objective as recurrence and the primary objective as a number of procedures? I personally feel number of procedures is important, but is not important over recurrence and progression in oncology. So this is an important point, a catch. We can see that if we have kept primary objective, kept a recurrence, so recurrence is not statistically significant, but the number of procedures came out to be statistically significant. Again, the comparison and creating the confounding variables we have seen, high-grade disease versus, if this study would have been done only in low-grade or low-risk cases, would we have given a better answer, right? Because we understand that the standard is mitomycin still in low-risk cases or low-grade cases. So low-risk stratification criteria to be followed, we will be giving a better answer instead of mixing a high-grade disease to it without hyperthermia, which is not a standard as of now. So what I want to say is that we need to really see the standards and then compare the article with the standards and see where do we stand. And finally, I think the critical appraisal, we should really think, as you rightly said, the transparency, the accuracy, the purpose, the utility, the proprietary, accessibility, and specificity. And at the last, we should also think whether we can apply this knowledge in our current practice or not. Somebody has published it. With due regards, we need to learn from the journal club multiple things of research attitude also. So whether we can apply this as per se, if I ask you, Keshav, will you able to apply
Ankur,
this?
I would like to interrupt. Ankur, I would like to interrupt. I want to hear one quick comment from Dr. Bakshi, and we want to wrap up to go to next session. That's too much late.
So actually, Ankur has actually summed up it actually well. I mean, the presenter has to look at these points very clearly when you are presenting a journal club like article. And last is, as we were listening, whether this will be grossly applicable or not. If you finally see the RFS in the control and the intervention, that particular object looks a little difficult. That's what probably. I mean, back to Ankur, because the points and you're saying something in the end.
So thank you, sir. I think we can end this saying that we need to really see that whether it's applicable, and we need to, at the last, we need to find the limitations and gaps so that this topic can be further studied with a better study design and to get a better answer. So I think this is also we need to learn that if we need to do this study, how we will perform this study with the understanding the strength and limitations of the study. I think back to
So
over to
just
Dr.
one more thing, as you have aptly quoted, just one last point to be added. As you
Yes.
have said that this was invented in order to avoid resection in patients who are way too comorbid or frail in order to undergo surgery. They should have mentioned about the comorbidities of these patients because 4 of these patients had already died within a year despite having a low-grade malignancy. So in fact, these are patients with poor performance status in order to apply the applicability of these results in order to our population for this. Sure.
So true, very true. Yeah.
So
I
we
think
move on.
back to Dr. Surekha. Over to you.
Yes,
Yeah.
sir. Thank you, Dr. Bakshi, Dr. Ankur, for helping the resident to understand the nuances of this journal and the article. Thank you, Sumit, and other participants. We'll move quickly to the next journal club article, which will be presented by from BHU. Uh, I think from BHU, Dr. Rohan Shankar is there, who will present the journal club. And we have our expert for the session, Dr. M.S. Ansari sir, Dr. Amilal Bhatt sir, and Dr. Mukesh Arya sir. So, Dr. Rohan, are you there?
Yes, I'm trying to share my
Yeah.
screen.
So, can you share?
Keep it within the time frames. Huh? Okay.
Right, sir. And the residents from SMS Jaipur, Dr. Navdeep, Dr. Sudeep will also be part of the session to interact and ask questions.
Dr. Sureka, can I just interrupt here? Dr. Sanjay?
Yes, sir.
I don't know whether our residents were given this article. So probably I'm not aware whether they are given and whether they can do the critical appraisal because without the article. Uh, so,
They were given, sir. They were given the
they were given? Okay,
Yes.
fine. Thank you.
Both the
Go ahead,
presenting
go
as
ahead.
well as the learners were given.
Okay, go ahead.
Right. Thanks.
Good morning. Is my screen visible, sir?
Yes.
Yes.
Good morning, faculty. My name is Dr. Rohan Shankar. I'm senior resident third from IMS BHU. Today we'll be discussing on the journal. The title, Does Preoperative Testosterone Administration Decreases the Complications in Distal Hypospadias Repair with Erythroplasty? And initially, it was published in Journal of Urology by American Urology Association. It was published on 17th May 2023. The primary authors Carl F. Gorbatsky and Samir Mittal. The primary work was done in the Children's Hospital of Philadelphia and Rainbow Babies and Children's Hospital. And the support for the study was given by the National Center for Advancing Translational Sciences. The need of the study was, since we all know, uh, the androgen stimulation before hypospadias repair is a controversial thing because despite it being used since decades, it has been controversial due to the lack of granularity of the prior studies on the technical details and the patient characteristics, which limits the ability to identify the subgroups which will benefit more of the patients in such range. So we have to consider the parameters which will decide which will influence the decision making, surgical and consideration for the preoperative androgen stimulation. So in this case, improved analysis is crucial for the informed decisions in hypospadias repair. The current challenges in the arthroplasty is basically the diversity of the phenotype of the hypospadias patients because there is a heterogeneity in the meatal location, arthroplasty length, glance width, and the type of penile curvature and penile tissue character. And there is no such a particular surgery which is completely, we can say, free of any complications. So we still lack a very ideal surgery. The challenges which come to the surgeons in identifying the factors which may lead into complications. So initially there is difficulty in identifying these risks so that the surgeons can be prepared for this thing and can mitigate the complications on follow up on operative procedures. So for example, if there is a small gland size that itself is an independent risk factor for a challenging distal hypospadias repair. So earlier there was a so that testosterone will enhance the penile size and glands width. So this thing need to be studied further. The further difficulty in the performing studies is there is difference in the various practices which are done at different institutes. They have a different protocol, different surgical practice. So this thing also comes into as a hindrance. And as previous findings have already showed that there is a dose-dependent relationship between testosterone and gland swell. And coming to the ethical considerations, routine use of testosterone administration is also not uh, completely wise, and there should be informed decision making for the conflicting data on the overall benefit and the complications. The objective of the study was it was studied retrospectively to evaluate the impact of testosterone administration on the post-operative complications, specifically in the patient who underwent distal primary hypospadias repair with urethroplasty. The hypothesis was that whether the testosterone administration significantly decreases the complications in this repair, and there and the dose dependent relationship with the glass width adds weight to this hypothesis. And there was a prospective, uniform, and standardized data collection in the preoperative and intraoperative and postoperative settings in all the distal hypospadias patients, and the standardized clinic and operative documentation was made to avoid to get a standardized data collection, and the templated post-operative and follow-up notes for the comprehensive evaluation was done. The primary primary patients who underwent primary distal hypospadias repair with rhinoplasty in the year between 2015 to 2021, and there was inclusion of distal and mid-shaft hypospadias patient with the meatal location being defined post-degloving. The collected informations were patient demographics in the form of age at the time of surgery, meatal location, T administration status, the length of the arthroplasty, type of the repair, glandular width size at the initial visit at the clinic and at the time of and the intraoperative period. And additional data which was derived was change in the glandular width between the initial visit at the surgery and post-operatively complications also studied. Glandular width was measured with the help of calipers at the clinic and at the table of under general anesthesia. It was done between the widest part of the ventral aspect of the glands, just below the corona. The exclusion criteria for the study was those patients who did not underwent formal arthroplasty and whether there was and the T administration was unconfirmed. These were totally excluded, and the additional exclusions were patient who underwent multi-stage repair, a redo repair, and a hypospadias repair, and the epispadias and extrophy complex patients. The testosterone was administered at the dose of 2 mg per kg via intramuscular injection. It was given either in two doses. The two doses it was given 5 and 2 weeks prior to surgery, and when a single dose was given, it was given 3 to 5 days, 3 weeks prior to surgery. And in case of delay in surgery, the surgeon's reassessment whether he wants to add a testosterone dose additionally was totally on the surgeon's discretion for the use, dosage, and the number of doses, and the timing and the surgical repair time. The primary endpoint was
In
to
between,
focus.
I would like to request our expert to intervene whenever they want.
The primary endpoint was to
Don't
study
continue.
whether the administration with post-operative complications, and the complications categories were in the form of fistula, glass dehiscence, repair breakdown, and meatal stenosis. And secondary endpoints was to evaluate the patient characteristics with post-operative complications, the initial glass width at the age of the surgery, and the type of the urethroplasty. The data was validated in a rigorous manner, and all the patient charts were manually reviewed by the two independent reviewers so that the accuracy of the variable of interest can be determined. The statistical analysis were done for the continuous variables in the form of median and interconnected range. Categorical variables were done in the form of counts and percentages, and the strata version 17.0 for use for statistical analysis. And the non-parametric continuous variables were assessed by Wilcoxon rank sum tests, and parametric continuous tests were used in the form of t-tests. Multivariate logistic regression was used to study the various independent risk factors with the post-operative complications. And statistical measures were in the form of odds ratio, and the 95% confidence interval was used. The statistical significance value was kept less than 0.05 for all the analysis. Coming to the results, there were 543 patients which were screened out for the study, and out of which 368 met the inclusion criteria for the primary single-stage distal hyperspadias repair with urethroplasty. The testosterone was administered in 133 patients, that was 36.1% of the patients preoperatively, and control group was 63.9% who did not receive the testosterone. Patient who received testosterone, the dose stratification was done in the form of one dose was given in 17 patients. Majority of the patients underwent two doses, and that is 112 patients, that is 84% of the patients, and only four patients received three doses. Coming to this was a chart showing independent risk factors and post-operative complications. As you can see, at age after surgery was having no significance, and the initial glance width was more in the patients was small in the patient who underwent testosterone, and glass width at the time of surgery was more in the patients in the time of those who undertook testosterone. So these two things had a significant value. The erythroplasty length was not significant. Most of the patient underwent Thiers Duplet procedure. As you can see in the no testosterone group, it was 83% of the patients, and the testosterone group, it was 94% of the patients. Coming to the only procedure, those patients who are not given pre-surgery testosterone, it was done in 13% of the patient. That is a significant amount. The non-testosterone group. The complication type was having no significant association among the testosterone and non-testosterone group, but as you can see, the testosterone group was having 12% of the complication rate, and no testosterone was having 15.7% of the complication rate. The most common complication was fistula in the surgeries. Coming to the logistic regression of for complications, and on the univariate analysis, the initial glance width and the uretroplasty length, they were having a significant value. But in this univariate analysis, testosterone administration was not having a significant value. On the multivariate analysis, initial glance with uretroplasty length, as it was there in the univariate analysis also, testosterone administration was having a significant value in this case. When we were comparing these variables in the patient who underwent complication and no complication, there was no much significance. But as we can see, those patients who underwent complication, there was a smaller initial glance width and glance width at the time of surgery. The dose-dependent analysis resulted that all the complications in this study happened only in patients who underwent only two doses. I think this was mostly by chance, but none of the patients who underwent one or three doses of testosterone prior to surgery, they did not have any complication. So initial glandular width and uretroplasty length was having a significant association with complications, and initial glandular width and uretroplasty length and age at the surgery was not effect modifiers in this study. As we can see, the odd ratios for all the variables depicted in the chart. Coming to the discussion. So in this study, we were able to
one question in between was how was the mode of administration decided for all patient?
Sorry, sir?
I think mode of
they have given injectable.
It was intramuscular 2 mg per kg.
Intramuscular, yeah.
Yes. So in this study, we were able to explore the surgical implications of biometric effects of induced by the testosterone. And till date, it is the largest retrospective data studied till date, and we was in a way able to fill a part of a gap in the knowledge regarding the relationship between the T effects and the surgical outcomes. As the findings were that T administration was significantly associated with the reduced odds of post-operative complications, and initial glance width and erythroplasty length was also significantly associated with complications. But it was in contradiction to the previous studies, as in Menon et al. Study, altogether 91 cases, higher risk of wound dehiscence were there in the patients who underwent testosterone therapy. And Godzua et al., in which 30 only repairs were performed, and there was higher healing complications in the testosterone group. That was 30% when it is compared to non-testosterone group. And this current study, there was no significant increase in glass dehiscence, which was one of the complications in patients who underwent two-dose testosterone group. So the uniqueness of this study was...
Dr. Rohan, maybe you just stop here. Maybe the teachers can ask from the students or maybe give their perspectives. Yeah.
Okay, these I think the basic Rohan, I think they have not evaluated in the sense the better things would have been they have evaluated what is the size in increase of the phallus gland size and then urethral plate size improvement. You see, the as far as result is concerned, results are there are different variables, other variables that also comes into the uh, picture. So how they have made this uniform in all operating surgeon, how many of these
Yes,
cases
sir.
were looked by the senior trainees? How many of the person who has operated? What was the experience in both group? Second one is type of urethroplasty also. So type of urethroplasty in most of the cases they have done tierce duple. So there are difference in the results of type of urethroplasty means only as well as this one Thies Duple and TIP. So these results have to be evaluated in that one. The better will be the purpose of your testosterone administration is whether there is increase in the size that makes the genitalia to be handled in a better way during surgery than the total outcome, because total outcome becomes totally different in all these.
Yes.
Rohan, have they said anything about this during discussion? Have they discussed
Yes,
this
sir.
one?
Yes, sir. I'll come to this. So in this study, most of the cases were operated by CS Dubé repair, as there was
Yeah,
a
yeah.
larger granular with diameter, so that led it to a tension-free rhinoplasty, and glass-make closure was comparatively easier in comparison to the patients who underwent only repair and those who underwent TIP. So all these characteristics we need to apply to
See,
the clinical
madam,
practice.
when I picked up zero stop, my question is why should it stop in Mumbai?
Mandani sir, please mute yourself.
Okay, go ahead, Doctor. But Dr. Mandani probably just had a.
Yeah, yeah. Yeah, Rohan, have you see, have they given the criteria of what was the size increase in the glans and penile length? And third thing
No, sir, they
is,
have not given. Yes.
so that is more important than these results, because the results, there are so many variable. You see, they have not mentioned about this. Have they mentioned about this one? The spongiosum, development of the spongiosum, development of the this one urethral plate. Third thing is what was the length of the size, the hypoplastic urethra. Then the glans size. Was there any difference in glans size? So all these in distal hypospadias repair, these are very important criterias. And the second thing, then the patients which I have taken, and other one is operator also. How many of them were that? How many cases were they similar one? After we can come to the conclusion of the results affecting if we take all other criteria which are similar, and then we can have.
Yes, sir. So they have altogether in their institute, they have selected 11 surgeons, and they have made two set marks for like they have given the granular width. They have to be measured between the widest part of the ventral aspect of glans and just below, just at the level of corona. And the second thing was the complication part. In this part, they have not only taken those complications that in the form of those who might be needing a reoperative procedure or in some like fistula or dialysis. They've also taken those complications which may not need any surgery, any intervention in further follow. So in this thing, in a way, they have since they have excluded all the, there might be an argument regarding this that they should be non-surgical means should not be included. Most of the surgeons will tell they should only consider complications. It might need a surgical complication.
Okay.
And since they have excluded all the mild variants, like they have excluded the mild distal variants in which there is no need of an erythroplasty, and they have also included the midshaft meatal locations, and so in a way they have a higher complication rate. If they will not exclude these mild variants, the institutional complication rate is 6 to 8. But in this because since they have excluded, it is ranging between 12 to 16%.
Okay. So,
So
Doctor,
I request Dr. Ansari sir to make a quick comment and we can wrap up this.
Oh, yes,
yes.
So, Dr. Rohan, can you go to this limitation of the study? So you just tell what may be the biggest flaw of this study?
The biggest flaw is like the baseline characteristic differences and surgeon bias. Surgeon bias in the form of surgery, and different
Yes,
surgeons have a different
yes,
someone wants to
because
give a single dose of testosterone.
agree. It's so because it is
I-
already, we are shooting over time. So it is
I
a
think
retrospective.
can I just come in here?
Please.
Doctor, SMS residents didn't have anything to do with this probably. So I think I would request the chairpersons to ask something to the SMS residents if they want, because I don't think they were included in part of
Okay, so Dr. Dr. Bhatt sir has asked a lot from Rohan. We may ask from the SMS resident. This Sudeep, from
Yes,
your
sir.
side, sir.
There are three residents.
Who are they, sir? Let us see the face,
So the
sir.
discussion part should have been with the SMS residents, right?
Okay, so yes, okay. So where are they, sir?
Sir,
They are here.
Doctor, yes, Dr. Prashay.
Dr. Navdeep, Dr. Sudeep, and Dr.
Sudeep is there. Prashay is there. So Prashay, one doctor.
May I ask a question, sir?
No, so first you have to reply. Sudeep and Prashay. He
Yes,
said,
sir.
it was a retrospective study. I just got what may be the flaws of retrospective study when it is clinically result oriented in a surgical procedure. You tell 2-3 points.
So, firstly, if it is a retrospective study, in a prospective study, we are seeing the results ourselves, but we don't know what happened in the past and what's the data that has been collected, how much that is real or
Selection bias is one of the greatest
selection bias is
flaw.
there.
And this all depends. Isko testosterone de do, isko mat do. Who decided that? What were the tissue characteristic? What Professor Bhatt said? Spongiosal quality, urethral plate width. They only talk of phallus length and glans width. There are many 20 factors in hypospadias. And secondly, there were 11 cooks who were making soups in the kitchen. Did you see?
Yes, sir.
One may be of the standard of Dr. Bhatt, and another may be of a smaller stature like me. So obviously, Dr. Bhatt's result will be superior than me.
Like me.
Yes.
But there
they
is
were
actually
11 cooks.
experience makes the difference. That is true.
Fully agree. Yes, sir.
Right, yeah. Experience makes the truth. So these things has to be. So rather the things which would have been that, you see, if you apply, whether you apply local testosterone or systemic, whether that make the facilitate to do the surgery in a better way, to taking the suture, to have the proper approximation of mucosa, getting the tension-free closure of the glans as well as the urethroplasty. That should be the objective, and that makes the ultimate difference in the results.
Yes,
And
sir, I have a doubt also.
as Hari has pointed out, because the size, there has to be a definitive criteria. Okay, they might have taken, okay, 2 centimeters is the size, or as per age, how much was this small length? Accordingly, the testosterone has to be given, but not in all.
Sir, I have a small question, sir.
Yes,
May I ask a small question?
Dr. Prashay, you can put your question in the chat. Dr. Prashay, hold on. You can please put your question in the chat box. Dr. Ansari would be more than willing to answer.
Okay. Thank you.
Actually,
Dr. Prashasi is part of the discussion team. So
I know, but we'll include him in the next program more prominently. So we need to move on also, sir.
Okay, thank you.
I will just, because they were decided last night only, the participants. So I'm sure that they were not given the
we all would be
article
more
and
than willing to and we'll answer through the chat box as of now. We will move on with the program. Thank you so much,
Thank you, sir.
Dr.
Thank
Bhatt,
you so
Dr.
much.
Ansari, and Dr. Prashas, Dr.
Thank you, sir.
Sudeep. So the next, you can stop sharing your screen now, and the next we move on to the surgical part of this teaching program, and this is today we have TURBT being taught how to do it properly and comprehensively by Dr. Anil Mandhani. Sir, you can share your screen now.
Can you see the screen, please?
Yes, sir.
At the same time, we have the residents from PJ Chandigarh for this session.
Yeah,
So,
if you want to answer, ask the questions in between, ask that in between itself.
And the chairperson. And the
Yeah.
chairperson.
Dr. Nikro,
Dr.
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 Vikash,
Hemant
Dr.
Bhatt.
Manoj Sharma. And for this session, we have our chairperson, Dr. Vashni sir, and Dr. Hemant and Dr. Bishwajit Singh sir.
Yeah. Please start.
Yeah, good morning, everyone. And thank you very much, North Zone. And I really appreciate this initiative of North Zone to have started this kind of program, because I can see many residents, which usually you don't see in big halls in national or zonal conference. So I know this is the simplest, one of the simplest procedures in urology. But if you honestly ask me, this is the most difficult procedure to do. Unfortunately, in institute, when I was in SGPGI, most of the faculty used to detest this, doing this procedure, and usually it was left to residents to do it. So just to introduce you, just recap that the bladder cancer is now, according to the latest Globocon, is the sixth common cancer in men. So it is, I mean, urological cancers, three of them are in top 10 cancers in men across the world. And this slide, this is data from SGPGI. It does show that more and more young people are developing bladder cancer, probably exposure to pollution, smoking, and maybe some unknown factors. So clinical spectrum, around fortunately, majority of the bladder tumors are non-muscle invasive, but 30% of tumors, they do recur at 3 months, about 60 at 1 year, and 30 to 40% non-muscle invasive tumors progress to muscle invasive bladder cancer. So this is the standard teaching of doing TURBT. Conventionally, I think most of us, barring few surgeons who are using laser, we are using a cautery current, monopolar or bipolar, and resecting the tumor in piecemeal. So you can appreciate that when you remove the tumor piecemeal, we do not know when we take deep biopsy, like this could be cancer and lurking at this point. But when you take a chip, you might miss the area where the deep part of the cancer has invaded the detrusor muscle. So logically, taking tumor by chips, though you do deep resection, but most of us are slightly frightened to go beyond detrusor and reach up to the perivesical fat, because this might lead to perforation and added complications. So there is a high chance that you may miss a tumor at some point on the bed of a large area bladder tumor when you're doing resection conventionally. So this is the procedure which I've been doing for the last 10 years. And I think most of the urologists are adopting to this. It's called en bloc TURBT, or en bloc resection of the bladder tumor. When you remove the whole tumor along with the detrusor muscle. So once you remove this, you can at least have R0 resection, which we describe in laparoscopy and open surgery. So maybe you can describe that R0 or R1 in bladder tumor resection by endoscopy. The problem of en bloc tumor for maybe 3 to 4 centimeter size is of removal. I think we'll discuss that aspect, how to remove that big tumor once you finish doing en bloc resection. So this is a standard thing in any subject of medicine. Unfortunately, science is not a fact. Most of our knowledge is not based on facts, and majority of it is based on conjecture and evidence which we synthesize. And there are so many biases, as you could see in last two journal club presentations, that how deficient was the knowledge. And just for the sake of publications, we keep dishing out such knowledge because there is so much of pressure to publish. So the recommendation and the standard guideline is, once you do TURBT, and even if you're seeing detrusor muscle, you need to do restaging TURBT. So this is the knowledge, and this is in the guideline. Why so? Because in literature, majority of cases, what you see is that you do not find detrusor muscle, or you find residual tumor, which is the major reason for recurrence after TURBT. So that's the reason relook TURBT is recommended. But mind you, these recommendations are when you were doing conventional TURBT, not the en bloc TURBT. So we need to really think in different way, out of the box, and maybe revise guidelines in future. So how do we define a good TURBT? A good TURBT should eradicate macroscopic tumor. So whatever you're seeing endoscopically should come out. Underlying bladder wall, I mean, at least you should see some part of perivesical fat at some area close to perforation. We call it a near perforation, and a resection of the edges. Once you remove the visible part, you should go around the bed and resect the even healthy mucus, some part of healthy mucosa before cauterizing that. Now, as I said, the problem of non-muscle invasive bladder cancer is recurrence. So why does recurrence happen? I mean, is it really a recurrence, or probably because of inefficient technique we apply to remove it? So it could be inherent nature of the tumor, provided you are leaving that area, leaving that tumor at the bedside. Or as we think that it is a field change effect. This theory is also in doldrum, but standard teaching is in TCC bladder, it's a field change. So there are multiple spots for development of cancers, which we don't see with the naked eye, or even a modified cystoscopy using NBI and other kind of variable cystoscopies.
Sir, one question in the chat box is all experienced surgeon also doing DTRBT in T1 G3 cases if detrusor seen in the biopsy report and not involved?
My approach is different. I do en bloc, so I don't do it. But yes, I think most of us, maybe some of the participants can answer. They're doing relook TRBT. So I don't do relook TURBT because I'm quite sure about my resection, as you will see in the video when you do en bloc resection. So the recurrence probably is because of inadequate treatment, or you may say inadequate imaging. I mean, whatever resources we have is not adequate to see abnormal area in the bladder. So this was one of the trials which compared NBI with the conventional white light. You see the only difference which was found, like if you are using NBI narrowband imaging, you can pick up malignancies or small tumor in 11% higher patients. So the question is, if your difference is around 11%, will it make any difference in long run, like 1 year or 2 years down the line? Will it, even if you miss small tumor, will it make the difference? Unfortunately, we do not have the answer. So we did this study of going beyond NBI or some optical imaging. We did random biopsy. You remember earlier in my residencies, we used to take random biopsy to see presence of CIS or any kind of tumor, even if mucosa is looking normal. Then this practice was stopped. So we kind of did this study, taking random biopsy and analyzed a microRNA, which is a precursor of malignant growth. I mean, if the growth is higher or the cell growth is higher, we presume that some microRNAs would be overexpressed. So we did RT-PCR studies, taking random sample. Like what you could see is the red spot is a normal looking area, and the red spot is the tumor bed, which initially I said that when you are taking random biopsies, you can miss it. But if you're seeing absolutely normal area, do we have cancer developing at that area? We do not know. I mean, there is no way to find out whether there is a cancer or not. That is one question. Second question is, even if there is a cancer and you're not detecting it, how will it affect the future course of the disease? We do not have the answer. So by taking random biopsies and analyzing microRNAs, we could find that, I mean, we took control as normal person in a BPH while doing TRP. We did take random biopsies on normal looking bladder. So we found that the expression of microRNA was much higher in normal looking mucosa in patients with bladder tumor than normal looking mucosa in BPH. So it's just a common knowledge that genetic changes precede morphological changes. So what if you find a normal looking mucosa to be genetically abnormal? Will it change the future course of action or treatment? This needs to be found out, and this needs to be refined or defined, the way we are managing non-muscle invasive bladder cancer as of now. So we had a journal club. In journal club, we had about a article of chemoablation. You see, one thing we should realize, like use of a single dose mitomycin after doing TURBT, just to prevent reimplantation. Now, this theory of reimplantation is also a questionable theory. Like in that article, I mean, if I ask you what was the action, what was the mode of action that intravesical mitomycin was giving you significant reduction in size in almost 50% of the patients. So it was not that mitomycin was getting absorbed into systemic circulation and it was killing cancer cells. Mitomycin has a very strong local chemical reaction. And I think that is that was the reason that you were getting some response by frequent use, almost 3 mitomycin dosages in 1 week for 2 weeks. So it has an action of chemical cauterization. And I do remember one of our colleagues presenting in daily conferences of a complication where he used mitomycin in a female after doing a good resection of bladder tumor. She eventually developed vesicovaginal fistula because of local cauterization effect of vaginal wall through the bladder. So we do not know what would be the outcome of a reaction to mitomycin in one particular patient. So I know there is level 1 evidence, and guidelines also recommend to use mitomycin C. But you see, again, the question is, I always think about the reason. Like, one needs to be rational. Why are you using mitomycin, a single dose? How will it prevent reimplantation of bladder tumor cells? So the questions I may ask you, maybe some of you can answer me. So when you get urine cytology positive in urine, those are living cells. Why don't they get implanted on the bladder mucosa? You may say that they do get implanted in the injured site. So the question is, when you're leaving a raw area, then why not our recurrences are developing at the resection site? Unfortunately, there is no clear data, and we have seen ourselves that recurrence is not always at the resection site. So there is an adequacy of knowledge in every field in bladder cancer when it comes to surgical treatment. And unfortunately, we are not working in this direction to find true answers. And maybe some of you can, if you're really interested, to find answers to such questions. So let's go to the video and let's see how do I do en bloc resection. So this is what you saw. So I use standard loop. I bend it outward about 45 degree angle. So this is very important step. So if you bend this loop outwards, this not only helps you retracting the tumor upward, but also it helps you finding the base and creating hemostasis. So en bloc, if you ask me, I would say it gives better control of plane of dissection. You know that where your loop is and at what plane you are dissecting. It causes less bleeding. Field is very clean. You get muscle in all the specimen, and you do close to R0 resection. And of course, this would lead to lower recurrence rate, and of course, need for intravesical mitomycin C, which the resident should not mention or quote me saying that. But I know recommendation is to use that, but this can be questioned. This is one of the case. You saw the tumor on the left lateral wall. So what I do, I coagulate all around the tumor. You see small or large blood vessels, you just coagulate them, and you proceed with alternative cutting or coagulation current. So this is monopolar being used. You can use bipolar, but monopolar gives you a better speed and better control. The cut action is better with monopolar. You see, you're identifying each and every fiber. I mean, you know on what plane you are. So once you reach to, once you resect the tumor, this is one of the ways to remove the tumor. Of course, you cannot remove 4 centimeter size tumor. So I just cut it inside the bladder to remove it. I have tried using nephroscope, using forceps, but that doesn't work actually because it breaks the tumor. So this is a broad-based tumor. So I mean, any place in the bladder you can approach the tumor. It's not that tumor at the dome or neck you cannot do en bloc. You can do en bloc in every tumor present in the bladder. So the trick is you move from outward in, from side to inward, and from below upward. So these are the actions you should take. Now you can see there was a bleeder and an absolutely clear vision you get. And you can even modify the plane. If you feel that you have gone quite deep, you just change it and alter the plane of dissection. So this is the wide resection of the tumor. And I told you two methods to remove the tumor. This is another method to do morcellation. Morcellation, unfortunately, does not give you complete picture of R0. I'll show you in later part of my presentation, but this is one of the ways to do it.
Sir, I think you have a few minutes left, sir. We can.
Okay. No. I think you gave me 30 minutes, no? Sorry.
Including discussion, sir. Anyhow, so.
Okay, I'll just take 2 more minutes.
Yeah.
Right, sir.
Okay, so now you can see this is a large piece and you can ink the outer part. This is the detrusor muscle and you can actually stage the tumor beautifully. It's a TA or T1. This is a paper we publish. We found a higher muscle positivity in our block. And this is the paper by Sanjay himself. We proved that by doing our block resection, the recurrence rate was, or the survival was better. So this is another issue. It's very close to my heart. Like you must have resected the tumor present over the ureteric orifice. Now the questions which I would like to put to the forum is, have you ever seen ureteric stricture developing after TURBT? And do you stent? And the question is whether you put stent before TURBT or after TURBT. I prefer, because I have faced such problem, like this is one of the patients where I did not put the stent, because in literature they say you should not put stent because it might cause upper tract TCC if you're putting stent after doing TURBT. So yeah, so the Arblaw TURBT helps when you have so when you have, sorry about this count. So Arblaw TURBT helps when you have a tumor over the orifice. You can remove the tumor after putting the stent, because you sometimes, it happens like a large tumor, when you resect it, you may not find the ureteric orifice to stent it. So I think this is the last slide. I would say this should be the way forward to remove the tumor, because it gives you a better plane of resection, a good field, less blood loss, and probably once you start doing it, you can avoid relook TURBT. This is my perception, which needs to be proven. Maybe NordZone can take an initiative to conduct a couple of trials based on this. And one trial I can propose, some good Samaritan from institutes can take it, that after doing TURBT, and if you find a muscle is negative, you can make 2 groups. After doing Arblaw, you just do relook TURBT, and in another group, you don't do relook TURBT, and just observe whether there is a need for relook TURBT once you do Arblaw TURBT. So that's what I had to present to you, and I would be happy to take any questions. Thank you.
So thank you, Dr. Mandhani. I think it has been a very comprehensive coverage, and you have covered most of the aspects. And as far as the technical aspects are concerned, I am sure the residents would like to know from you that how would you like, how would you prevent an obturator jerk, which is common in the lateral wall tumors. And then there are issues. One is the preoperative MRI. Now the MRI has come in a big way, and BIRAD scoring is coming up for these bladder tumors. So how you place in your practice the MRI in these cases? And another one question I would like to ask is that the precision with which you do this bladder tumor resection, majority of the cases, except for the ones which totally involve the ureteric orifice, but the ones which are overlying a ureteric orifice, if you have a precise enucleation, I'm sure one should be able to avoid a ureteric orifice injury. And sure, that stent is required when you are not able to. So just few comments from you on these 2-3 points.
So obturator jerk is a problem, even with bipolar. Even if you're using bipolar current, it does happen. So the trick is you need to under-distend the bladder. You need to be careful. Bladder should not be over-distended. You just keep emptying the bladder, and you need to be very slow. And once that thing is in your mind, I think you can avoid perforation, but it can happen. I know you are inching towards using laser, which will avoid obturator jerk, but yes, that could be used. Laser, if you're good in using laser, that can avoid obturator jerk. Regarding MRI, I don't. I use MRI quite often, calculating virate scoring in low grade TA mostly, not in high grade bladder cancer. So I skip cystoscopy and replace that with BTA antigen and MRI. So I have reduced the number of follow-up cystoscopies.
Can I ask one question here?
Yes.
So, just on the point of en bloc resection and the pathological reporting of T1 and T2, see, beyond the trials, if you ask the pathologists how do they actually report TA, T1 and T2, most of their reporting is basically on our cut chips samples that the first samples, the initial samples that we send. On the T1 reporting is also predominantly on this. So what we decide for restaging is predominantly the pathological sample that we send the initial part. In the deep biopsy separately, what they mostly see is just whether the similar tumor is present or not, and whether they can actually identify some muscle bundles, which if no tumor else is there, they would label it as a deep muscle. So from the reporting point of view, the histopathological report is primarily based on the superficial sample. So what we are basically based is, this is a premise, the hypothesis on which we think that the en bloc resection gives a better histopathological sample. That is probably not true from the pathologist's point of view. Your comment on that?
I would like to disagree with you, because one of the pictures you saw, when you have a good piece of tumor and you make them understand what you have done, I think you see all the layers together. So you know where the tumor has gone, whether it has gone to lamina propria or lamina.
No, what I'm saying is the pathologists don't do a whole mount specimen histopathology to see the tumor in its exact
For prostate, they must be doing it, no? For prostate, they're doing it.
No, even for prostate, they are not doing it beyond the trials and beyond the samples. What they do is just they take a small slice of the area where they think the tumor is on gross examination, and then examine it under the slide. The same goes for the bladder tumors as well. So what we think theoretically that yes, the whole mount specimen should be giving
But
us.
Rishi, up to 1.5 to 2 centimeter chip. If you're removing the tumor, it will not be more than 2 centimeter. Even an oblong piece of tumor will not be more than 2 centimeter. So I'm sure any pathologist would have that facility to see a 2 centimeter wide tissue. That should not be a problem, because the picture I showed to you was 10 years ago. It was done in SGPGI. That is a beautiful picture. It's published in Indian Journal of Urology, where you see all the layers from epithelium to detrusor.
Okay.
Right. Thank you, Mandani sir.
Can I make comment?
Any
Dr.
comment from the
Gupta
expert?
wants to make a comment. Dr. Gupta.
Yeah, Gupta sir, please, sir.
No, regarding the tumor near the ureteric orifice and involving the ureteric orifice, these two are different categories. Near the ureteric orifice, if you see a tumor and you think that you can damage by doing your resection, whatsoever way you want to do, better to put a ureteric catheter, not DJ stent. And then you complete your job of resection of the tumor. At the end, you evaluate whether you have damaged the ureteric orifice or not. If not, you can take out the ureteric catheter, or next morning you can take out the ureteric catheter. Those which are involving the ureteric orifice and you have resected the ureteric orifice, my experience is that if you do with bipolar, you can see the ureteric opening very clearly. I don't know the mechanism, but certainly, and I do a DJ stenting, but only one warning, that after DJ stenting, don't put BCG, intravesical. Wait for the 6 weeks to take out the ureteric double J stent, then you can give, if required, so intravaginal installation of PCG. Because I have seen in a patient who developed tuberculoma of the kidney by using this intravaginal BCG, and then we realized our mistake.
But sir, one question. I'm sorry, Sanjay. With the wisdom of Dr. Gupta, I would like to ask him: have you ever seen upper tract TCC after putting stent following TURBT, which is a concern in the literature?
No, not. I have not seen.
Okay, thank you.
Okay, thank you,
Sir,
sir.
but I have seen the reverse. If you put a stent in upper tract TCC, I have seen a multiple bladder tumor in many patients.
That anyway, it happens in almost 4%. So whether to blame it on DJ stent or not, we don't know.
Exactly.
So I think we can go to the next session.
Yes, please go
Right,
ahead.
sir?
Yes.
Yeah. So thank you, Mandani sir, for a wonderful presentation, and thank you all the experts. So next session is on soft skill, and it will be presented by Dr. Shivam sir. And Dr. Shivam sir also suggested to include one of his residents to share his experience. And residents from SKIM Srinagars will also join to interact with sir. And expert for this session would be Dr. N.P. Gupta sir, Dr. Shamit Trivedi sir, and Dr. Rahul Gupta sir. So hand over to Dr. Shivam Priyadashini sir.
Thank you, Dr. Sanjay. So thanks once again for giving me this opportunity, and congratulations to the office bearers for bringing out and making this initiative of residency program. So I would request Dr. Sanjay and Dr. Rishi to stick to the points. It's almost 15 minutes late. I'm starting. So next time, try to become more punctual, right? Thank you. So what I would do is I would break up my thing into two parts. One is I will do the residency training, and 5 minutes will be taken by my resident, Dr. Sayam Nandavani, who would tell us his experience, because he has just passed out from our department, about how he felt about his residency training. So we all know the main objective of our residency training is not only to impart knowledge, clinical acumen, surgical skill, and develop clinical judgment, but also to develop a compassionate doctor-patient relationships, to improve the power of speaking, presentation, and interaction with the patients, to develop oratory, teaching habits, and leadership qualities, and to develop a research and innovative mindset. And because these residents are stressed out, we need to create a work-life balance by a full support from the faculty. So why do we need to improve the residency training? The problems today with the training in urology is definitely there is the period of training is short, because with the increase in the number of subspecialties and the vast urology knowledge and surgeries, the 3-year period is definitely too short. We do not have any standard curriculum. If we see all the nationwide, if we include all the training centers, there are some centers which have inadequate facilities. Some do not provide adequate exposure to the trainee students. Some centers do not have a proper teaching program. Some have poor research facilities, and definitely all residents do feel the burnout during their training program. The original residency program started when the urology was a very limited specialty, but now with the explosion of the knowledge and the various specialties like robotics, uro-oncology, female urology, andrology, urolithiasis, everything, I think the duration of the training period is too short. The current 3-year program is insufficient. And by the time the resident comes into a situation where he would start getting surgery and have some surgical freedom, it's his time to go from the department. And of course, he doesn't get enough time for genuine research and publications. If you compare it with the other centers in the West, in US and Europe, they do have a 1 year or 1.5 year surgery followed by 4 or 5 years of urology training, which should be the proper period. So we also lack in a structured and standardized training curriculum throughout the nation. So most training centers would lack that kind of a curriculum. Most trainees do not have a clear idea of what skills they have to they are going to acquire semester to semester basis. And there are centers which are focused on particular part of the urology training, some endourology, some laparoscopic, some robotics, some uro-oncology. So under these circumstances, the trainees actually have a varying level of skills and knowledge, and they do not get a complete and holistic urology training. So definitely, many of these centers do not give a proper operating exposure to these surgeons or the trainee residents. And most of them have to learn on the job after they have already been trained in the center, even for their bread and butter like QRP and PCNL. Research, of course, is one of the neglected component, and majority of the centers do not have a proper training program for research. So research should be definitely a part. So I suggest that during the MBBS period only, there should be some exposure to the specialties like urology. There should be a compulsory 1 or 2 week urology rotation so that these students after graduation can decide whether they want to go into surgery, and if surgery, whether they want to go into a urology. So ideally, it should be a 5 to 6 year urology program. The first year devoted to general surgery training, second, third year to intense urology training, fourth year, they get the full surgical freedom and they achieve the surgical skill in various urology procedures. And the fifth year can be dedicated to research, and they also get the teaching kind of a training to their juniors. So I suggest that there should be a standard, broad-based, nationwide curriculum for this urology program. Each program must satisfy the minimum criteria and should provide training in the various disciplines of urology. There should be at least a distinction between MCH and DNB programs, as is very evident in today's practice. A defined number of required supervised surgical procedures in each category should be laid down. It should be compulsory for institutions to ensure that the residents get stipulated number of surgical procedures before they exit the examination. The logbook maintenance should be made compulsory, and there should be a common national level exit examination for all programs. The academic program should include mandatorily regular classes with journal clubs, seminars, interdepartmental meetings, monthly audit of their procedures. They should be encouraged to participate in various conferences and workshops. There should be inter-institutional exchange programs also. And it's not just to punish the students who are not doing well. We need to give incentives and award the students who are meritorious and are doing good work. And besides the academics, we also should work on how to train them in the language, the oratory, the communication skills. Some of them they should also develop some training in photography and video editing for their presentations. They should develop leadership and teaching skills also. There should be a regular internal assessment of the candidates. There should be strict goals made for every 6 months of training, and maintenance of a surgical log should be mandatory, and minimum number of the various procedures should be specified. If the various goals are not met repeatedly over a 2-year period, the reason for the failure should be identified. And a 6-month training performance evaluation should be an integral part of each teaching program. I also suggest that many of the candidates, after passing out urology, some of them would be interested in subspecialty. Though that there are people who would like to go into general urology, we need general urologists also to serve the masses in our country. But some of these would be going into subspecialties, and there should be a subspecialty fellowship training program in the various centers. A limited number of fellowship positions in certain centers of excellence can be established, and this is important for developing the subspecialties. I also suggest that the Urological Society of India and the Indian School of Urology could be used as a supervising body. It should have administrative control over the urology training programs in the country, and the body should lay down the format and requirements and the minimum criteria for these training centers. And if certain programs do not fulfill the criteria, they should not be given the accreditation. This burnout during residency is a very common problem. We all know the residents are burnt out, they are stressed out, they are exposed to heavy work, they lose their autonomy, and the excessive focus on the data and the patient care, the too much of government insurance and the hospital rules, too much of filling the forms and etc. Brings out a lot of stress in the residents. Moreover, MCH residents many of them are married with little children in their family. So maintaining a work-life balance also becomes a major challenge to them. So it is important that we take adequate measures to reduce the stress. We need to provide a very supportive environment. We need to have a respect with each other. The faculty should respect the residents should respect faculty. As I said in the last presentation only, the residents were not given adequate time for the discussion and not adequate time. I would really apologize as a faculty to the residents that this was our mistake that we couldn't give you the time. So this interrelationship between faculty and residents is again very important. We start our day with a daily prayer or thought of the day, and that helps to calm down and reduce the stress amongst the residents and faculty both. We have also, and there should be a wellness education program. We can have a regular health checkups of both faculty and residents, and we can develop some social outings like picnics or dinners for the residents and faculty to reduce the stress. Besides that, we also should encourage extracurricular activities amongst the residents. We can encourage to have them music, painting, photography, and yoga and meditation classes, which we do quite often at our center. So the take-home message is the urology training program should be converted to a broad specialty with a 5 to 6 year training program. There should be a 1 to 2 year fellowship program in the various subspecialties at designated centers of excellence. There should be a common nationwide competitive entrance examination and exit examination in all the urology courses. There should be a standard broad-based nationwide training curriculum for all urology programs, including both DNB and MCH. There should be a compulsory research program in the training program, which could be a last year, or there could be 1 or 2 hours of every week intense research training to the urologists. We should encourage the use of communication technology for teaching. We can have nationwide classes. And why nation? We can have global classes, global seminars, global urology grand rounds at centers so that all residents in the country can benefit from these programs. We should have internal assessment with regular monitoring. Besides academic, we also need to improve the soft skills. We need to take measures to reduce the burnout and stress amongst residents. And USI and the Indian School of Urology could work as a monitoring body for the training program. So I thank you once again for giving me this opportunity. And I will request now my resident to kindly share his presentation. Dr. Sayam Nandwani, please come in.
Good morning to one and all. Very good morning to one and all. Thank you, NZUSI USI and Shivam sir for this opportunity. At SMS, we are made to believe that we need to add something to all these aspects of life, which add value or add meaning to these aspects. And that something happens to be our development or training, not only as a resident, but also as a human being, so that we can perform these duties to the best of our abilities and shine bright after 3 years of residency in the challenging globe. On the first day of our residency, we are given a logbook in which we have to jot down all the surgeries which we are doing and assisting. And at the end of our unit-wise rotation, we are assessed by the consultant, and marks are allotted according to the performance of the resident in the logbook. There's also a structured training and learning program which tells us about all the learning objectives, teaching learning methods in the syllabi for the MCH course. And all these learning programs and logbooks are freely available on the departmental website. At SMS, we firmly believe in the right to education, and which serves our motto of free education for all, as it can be seen in our YouTube channel, which is totally free of cost. And there's a regular resident teaching program in which the whatever the topic is, it is given transmitted live on Zoom and YouTube free of cost. Even the surgeries that we do are divided according to the years, what is expected of a first year, what is expected of a second year, and what is expected of a third year. And these surgeries are performed or assisted by us in the presence of a mentor or a guide. At SMS, we believe that focusing on health is as important, if not more important, as our professional careers. And hence, we are encouraged to do regular physical exercises, our mentors leading by example. We take mental health equally important as physical health, and we have regular meditation sessions, which are organized by the department to keep our neurons in check. We are very firm believers of God, and our every OT starts with a very small prayer, 5 minutes of prayer, and a positive thought for the day, which helps us to perform at a highest level. Our armory is jam-packed with the latest of innovations, be it completely modular OTs or the latest ESW machines with Dornier Compact Delta 2, or be it a Da Vinci dual console robot or a 3D laparoscopy. We also have training modules for the residents to train before hands-on on the latest equipment. We always believe that learning from the best has been always a habit at SMS, and we regular conduct of workshops and CMEs has been a norm at SMS. We also firmly believe that celebrating the festivals and events together helps not only knowing each other better, but also it keeps the family united. According to our teachers, there are 4 pillars for a resident, and each and every pillar has something to contribute to the training of a resident. At the end, I would like to say that in the world of Duryodhan, we should be an Arjun for Dronacharya, and I welcome all of you in my beloved department to witness our small bit or effort we do to raise and rise. With this, I conclude. Thank you.
Thank you, Sayam. So it's open for discussion. We can take questions.
So the residents from SKIM, if you want to interact and ask any questions to sir. Dr. Ami, Dr. Aki, Dr. Yunis, Dr. Karen.
Yeah, go ahead. Dr. Divana, don't share your presentation. So the discussion is going on. Dr. Sudhir, thank you. So do we have the Srinagar residents with us? Dr. Arif was just our examiner just a few weeks back.
Good morning, sir.
Good morning. Go ahead.
Sir rightly pointed out all the
Please
issues
introduce
that
yourself
residents
first.
face.
Please introduce.
Sir, I am
Please
Dr. Amr
introduce
Mushtaq. I'm a third year. I'm Sir Dr. Amr Mushtaq. I'm a third year resident in the Department of Urology at SKIM Srinagar. As you, sir, rightly pointed out, the various issues that we face as residents, including the hands-on training I really would like to, as you said, that there should be a structured curriculum, a semester-based teaching, so that we get a defined number of procedures at fixed intervals of time, so that we are like when we leave our training at 3 years, we should be able to do almost everything. We should be able to work independently. But most of the times it happens that when we leave our training, we have to learn on the job. So that is my answer.
Yeah, thank you. I think that's a very important thing to be. That's why I said that yes, you should have to have as much as possible all the armamentarium and all procedures to be done in that particular training center. But some of the centers may have lacked some particular kind of a procedure. That's why I suggested that we should have also inter-institutional exchange programs. Like if you are not having robot, you can come to our center to learn robot or at least observe it. So if somebody is not having a kind of a good lab exposure or kind of a good uro-oncology, then they can go to those centers. So I think that's a very good suggestion to be made. Yes.
So I would just like to have a quick comment from our very learned expert, Dr. M.P. Gupta sir, Dr. Samit Trivedi sir, or Dr. Rahul.
Okay. Shivam, what you said, I agree with you, most of the points, but my views are a little bit different actually,
Yeah.
See that what is the aim and object of the training program of MCH or DNB? Syllabus is very well laid down by both DNB and MCI, I will say. The question is, are we training a good general urologist? Are we training a specialist? The confusion today is, when we started, our aim was only urology. Our aim was not for subspecialties. But suddenly, during the last 20 years, the things have changed. So everybody want to become subspecialist during that curriculum of 3 years, 4 years, which is not possible at all. So the aim and object of the MCH program or DNB program is to have a history taking, physical examination, reaching to a diagnosis, how to investigate the case, and how he can be treated. These are the basic things should be taught to the students, and this is given in the curriculum. And after that comes the question of specialization. I think so they should be given hand-on experience for the lower tract endourology and endourology, PCNL, and ureteroscopy. If somebody want to become a laparoscopic, robotic, transplant surgeon, I think so fellowship is there. Now I'm happy to see that fellowship programs are coming up. So instead of changing this system from 3 to 5 years, let it remain at 3 years, give a basic general urology program in those 3 years. After that, those who are interested to go out into the, class 1 city or 2 city specialized center, they can go for fellowship program. So I think so if we make it 6 or 5 year program, then see the age of the candidate also. By the time he completes his MCH, he will be 30 plus or something like that. So you have to consider both the aspects, and you have to consider the nationwide. Whole country needs urologists. It is not only the class 1 or 2 cities needs urologists. So I think so this topic is very sensitive. This needs a thorough discussion. And I have already suggested to our previous secretary, late, unfortunately, he agreed with my concept. So why not to do a survey of the 5 years, those who have passed out and what they are doing? 90% of the urologists, I can tell you, I have done the other kind of survey also for subspecialties. 80 to 90% are doing general urology. Plus they are doing 1 or 2 subspecialties. Hardcore few persons, I will name them, they are only doing pure that subspecialty practice. 10% is the number actually. So are we looking for 90% or are we looking for 10%? So don't get confused. Our students are unfortunately totally confused today, because day one they want to become a transplant surgeon, robotic surgeon and all that, which is not possible.
Yeah, sir. Thank you, sir. Thank you very much for your comments. I just want to clarify that what I said is a direct entry into urology after MBBS and not after 3 years of general surgery, which is that's what I'm saying. That does. So that will rather reduce the period of training rather than increasing the training. Secondly, yes, we need general urologists, no doubt about that. But definitely the subspecialties should be developed so that we can give a kind of an expert kind of a care to the patients, those who require that kind of a care in the various subspecialty centers. So that's what my suggestion was.
Sir, can I just come in for just one comment is there,
Yes,
sir?
yes, go.
That
Go ahead,
regarding
go ahead.
the like all the residents, what confusion I see is that they want to be very independent and confident once they pass out to do a surgery. My take is not my thing is that during the training program, they should be learning the principle of a surgery predominantly, when to stop, when not to proceed, and what to do in case of a backup plan. As you get more number of cases, it's not possible to train a person to so as he can go independently and to train it with enough number of procedures. You have to learn as you go. So as you pass out, you know what is the basic principle, how to proceed, and as you add up the cases, you become more and more and more expert on that. So that will take some time. It cannot happen in 3 years. That is my take on this thing.
Yes, Rahul, I agree. We are in a surgical branch, right? So if you just avoid doing surgery, that doesn't make you a trained surgeon. So it's very important that if you are doing training in urology, you need to be trained at least in the basic surgical procedures of urology. If you're not trained during that period, you are not training surgeons. Then you are training physicians, right?
So that is why
logbook
becomes very important, sir. How many us look at the logbook of the candidates and reprimand the consultants who are responsible for that and not the candidate? See, we in DNB also we have a logbook concept. In MCH also we have a logbook concept. So now when the candidate opens up that logbook, hand on the heart, how many of us reprimand the consultant? Isn't the responsibility of the consultant to ensure who has taken up the responsibility of training the candidate adequately, means the basic principle number
Can
of
I say
cases?
something here, sir? Sir, I think this whole business of numbers
Yes,
is not, this whole business of numbers is not good, sir. Whether you do 15 TURPs or 20 TURPs, it doesn't matter. If you know how to do one TURP correctly, that is the thing which is most important. So logbooks and other things are all right, but basically it's the job of the trainers or the faculty in that particular institute to make sure that they teach the residents correct things, how to do. And as NP Gupta sir said, I totally agree with whatever he has said. It's our job to make them a complete general urologist, and rest is up to them whether they want to go into academics or research or for a super subspecialty. That is totally their prerogative. It is not possible to teach them all the subspecialties within 3 years of MCH or even within 5 years of MCH. So our job is to give them a foundation, give them the basic principles of urology, and then they can take it up from there. Once they pass out, what do they want to pursue? It's very difficult to provide all this at a single center, all the subspecialties. Even if you have exchange programs, that is not going to fulfill that lacuna. We cannot produce subspecialists after 3 years of MCH.
Impossible.
No. Just a little disagreement here. That yes, you should provide urology, but if you are not making them surgeons during the training period, if you're not allowing them to have hands-on experience in the surgery urology, you are not training them.
No, there is no debate
So
about that.
the
Of
basic
course,
surgical
there is
training
no
should be
debate
there.
about that. Yeah,
Shivam,
there is no debate about that.
Shivam,
No
I
doubt.
already just listen. I've already told you lower tract and endourological procedures. I think so. We should aim that for all. Like you have 36 residents, you train each one equally good in all these things. After that, let them come back as a fellow for your transplant fellow, for your robotic fellow. So I'm not against subspecialty. I'm very much for subspecialties. And one thing more I want to add you, by calling somebody and showing him 4 or 5 procedures or 1 week or 2 weeks is not going to make him a robotic surgeon. How much hard work we have gone through to learn these procedures, we know it. So making a half-heartedly giving 2-day PCNL workshop, you can't teach everybody PCNL, you know. You keep your hand on your heart and you say that he will become an expert PCNL surgeon. No, never actually. Let him do 1 year fellowship in PCN if he really want to become a good PCNL person.
So, sir, we can continue to debate on this, but
yeah, I know this is not a topic for today.
Fact is, the soft skills are important for the residents to take them through to their post-residency life. So with this, I think we should move on to our next session, which is the drug spotlight session. In this, we are going to focus mainly on the drugs that we commonly prescribe and not the clinical workbook discussion. It is going to be on the hands-on experience with the drug, what should be given, how they should be prescribed. And Dr. Sudhir Divana is going to present on alpha blockers today, and being moderated by Dr. Nachiket Vyas, Dr. Apul, and Dr. Pamposh there. So, Dr. Sudhir.
And we also have the resident from SMA, from the AIMS Jodhpur, Dr. Priyank Bhargava and Dr. Bikram Singh, who may interact with the presenter and as well as the expert in between. Thank you. Sudhir, you can share and you can continue.
Yeah, thank you, sir. Thank you, sir. Very good afternoon to everyone, and happy Makar Sankranti to all. Respected chairpersons, seniors, dear teachers, and all the residents, I welcome you all for this innovative resident program which has been designed by the North Zone Council. So my job for this, given that is given to me, is about the alpha blockers, which are one of the most commonly prescribed drugs by the urologists in a routine practice. So we all know that the common indications of prescribing alpha blockers being the benign prostatic hyperplasia, and most commonly we even give them these drugs to medical expulsive therapy for ureteric stones. And also once in a while you get patients of chronic prostatitis and chronic pelvic pain syndrome being managed with alpha blockers. Before going into the depth about the pharmacokinetics and dynamics of these drugs, first of all, we should understand about the distribution of the alpha receptors, which were in the lower urinary tract. If you see in the slide provided here, this is a diagram which was taken from the Campbell. Everybody might have seen this picture where the alpha blocker subtypes being alpha 1A, alpha 1B, and alpha D being distributed in the lower urinary tract. The alpha 1A receptors, androgen receptor, adrenergic receptors specifically, they are located and confined to the prostatic urethra, the capsule, the stroma of the prostate. And also the predominant component of the receptors are even located at the bladder neck and the base of the bladder. Whereas the alpha 1B receptors, they are actually the receptors which are located in the vascular smooth muscle. That is very important because once these receptors are being blocked, the chances of having cardiovascular effect in terms of having symptomatic hypotension or dizziness would be higher. So these receptors are focused at that level. Whereas the alpha 1D receptors are also located, but in a lesser percentage when compared to alpha A receptors in the prostate and also in the detrusor muscle as well. So predominantly these alpha blockers were classified into groups basically based on the alpha adrenoreceptor selectivity and also the serum elimination half-life. Like if you see this diagram which is taken from the Campbell, where the non-selective blocker, that is the phenoxybenzaimine, was the one first which was approved for the treatment of lower urinary tract symptoms with BPH, and then subsequently the alpha 1 selective blockers came up, the prazosin, the alfuzosin, which initially was the immediate release formulation, and then subsequently long-acting drugs came up in the form of terazosin and doxazosin and alfuzosin in a sustained release form. And the more highly selective alpha blockers being the tamsulosin, silodosin, and naftopidil. So if you see these drugs, the initial drugs, these are even divided as first and second generation drugs and third generation alpha blockers. So as you move from 1 to third generation drugs, the selectivity increases. The first and second generation alpha blockers, if you talk about, of course, these drugs are not routinely prescribed nowadays for BPH, but you should know a little bit about the side effects and how they were prescribed previously. The phenoxybenzaimine, which has a primary limitation of having high side effects because of non-selective nature, the most important side effect being the hypotension. Of course, prazosin, the problem with prazosin is the short-acting drug because it has to be given in multiple doses. So the drug compliance would be a problem with this drug. Hence, then the long-acting terazosin and doxazosin came up, and the main problem with these drugs being the first dose effect. That is, when once you give this drug, the patients tend to develop risk of hypotension, and at the same time, they need titration. So you have to start with the lower dose, and then you have to slowly increase the dose and then titrate to a given patient. Just to cover up about the naftopidil has a higher affinity over alpha 1D receptors. And since these 1D receptors are even involved in the detrusor overactivity as well, and also the naftopidil has shown to be have an inhibitory effect on C fibers. So this drug is in patients with associated overactivity. This drug is one of the drug which has shown that has higher activity in reducing blood detrusor overactivity as well. And another proposed importance of this drug is the lower incidence of sexual dysfunction. So in sexually active patients, yes, this is one of the drugs which can be prescribed. Now coming to the most commonly prescribed drug being the alfuzosin, tamsulosin, and celadosin. The main advantages of these drugs being they are highly selective. They are given only as a once a daily preparation when compared to the previous generation drugs, and they don't have any first dose effect, and they don't need any titration. And obviously, since they are more selective, they have less side effect profile. Let us now discuss into a few points related to the pharmacokinetics and dynamics of these commonly prescribed drugs. Like in the slide provided, you can see the comparison of tamsulosin, alfuzosin, and celadosin. The alpha 1 blocker selectivity, if you see for tamsulosin, for alpha 1A and alpha 1D is equal, but however, it is had higher selectivity when compared with the alpha 1B. Whereas celadosin also, if you see the alpha 1A selectivity is significantly higher when compared to tamsulosin. The same thing has been provided in the next line where you can see in celadosin, it is 162 times higher selective for alpha 1A compared to alpha 1B. So that's why the side effect profile would be lesser. So it causes less amount of hypotension. Now, if you come to the rest of the pharmacokinetic parameters like tamsulosin, if you see the bioavailability is higher. Of course, all the three drugs have a higher protein binding capacity to the range of around 90% and above. And the tamsulosin is predominantly excreted in urine. Whereas if you take alfuzosin, which is primarily metabolized by the liver, it is significantly excreted in the bile or feces. And one thing which I want to highlight here is the time to maximum plasma concentration, which is very lower for celadosin, which implies the saying that it has a rapid onset of action when compared to the rest of the two drugs. Now, if you go one by one, a little bit few points into the pharmacokinetics, tamsulosin in fasting state, it is actually going to be absorbed in 90%. That will lead to a less duration of action. That's why it is always recommended that food, it delays the absorption of the tamsulosin. That's why it is generally given 30 minutes after a meal, and that too, it should be at a fixed time every day. So this will decrease the absorption and it will prolong the action of tamsulosin over 24 hours. So that's why it is generally recommended to be given after food. And it undergoes extensive metabolism by the hepatic cytochrome P450 enzymes. And the most important thing is in patients with hepatic and renal dysfunction, in particular in mild and moderate dysfunction, tamsulosin doesn't need much of a modification. So the same drug can be prescribed in the same dose. However, in patients with severe hepatic dysfunction or in CKD with less than 15 GFR and creatinine clearance, and in ESRD patients, the safety of this drug is not studied, and so hence it should not be given in those group of patients. Coming to alfuzosin, it is predominantly metabolized by the liver, and that's why it is definitely contraindicated in patients who are having moderate to severe hepatic dysfunction. And in mild dysfunction, obviously you can give this drug. And in patients with severe renal dysfunction, less than creatinine clearance of less than 30, it should be given with caution. However, it is not contraindicated. Coming to celadosin, similar to the previous drugs like tamsulosin, with food also the absorption of the celadosin is decreased, and so it has to be given only like tamsulosin only, and it is extensively metabolized by the UDP glucuronide transferase and other enzymes as well. And it is contraindicated specifically in severe hepatic dysfunction and renal dysfunction cases. And when you have a patient with a moderate renal dysfunction, the dose of the celadosin should be reduced to 4 mg. However, in severe renal dysfunction and hepatic dysfunction, of course, it is anyway contraindicated like other drugs. Coming to drug interactions, a few points related to drug interaction is very important. Like since these majority of these drugs are metabolized by the cytochrome P450, so those drugs which inhibit the CYP3A4 and CYP2D6, these inhibitors, when these are being taken by a patient, obviously you have to reduce the dose of your drugs or better to avoid these drugs. Particularly ketoconazole and erythromycin are shown to be the strong inhibitors of cytochrome P450, and also cimetidine has shown that when the patient is on cimetidine, the clearance of tamsulosin is decreases by around 25 to 26%. So hence the dose should be reduced. Of course, in PDE5 inhibitors, when you combine an alpha blocker with them, generally there is a tendency of symptomatic hypotension. But of late now we are getting combinations of alpha blocker with tadalafil or PDE5 inhibitors in a lower dose range, so that this side effect is avoided. Whenever you have any hypersensitivity to these drugs, obviously sometimes when you prescribe these medications to a patient, once in a while patient comes saying that the moment I took this medication, he had some allergic response in the form of itching or a rash or anything. In such patients, you should better to completely avoid that drug. Since many of our patients are elderly and they are on drugs like atenolol, nifedipine, enalapril, digoxin for cardiac drugs, so these drugs there is no need to modify the tamsulosin when the patients are on these drugs. Alfuzosin, same like tamsulosin. However, since alfuzosin is predominantly, when compared to tamsulosin, predominantly more hepatic metabolism, so we have to be very careful when patients are like these inhibitors like ketoconazole, itraconazole, and ritonavir. So it should be contraindicated with them. And with cimetidine and also the other antiviral drugs which are given for hepatitis C virus infection also, these drugs also will increase the drug levels of alfuzosin, and hence in such patients it should be avoided. Coming to silodosin, like previous drugs, it is also contraindicated in patients on ketoconazole and itraconazole or clarithromycin, whereas patients specifically who are on cyclosporin, in them it should not be used. One group of patients which are the elderly patients also, sometimes we have to choose the alpha blockers, like particularly alfuzosin has been shown that in elderly patients, the drug metabolism is delayed, leading to increase in concentration of drug. Hence, if you have a patient who is elderly beyond 75 years of age, it is better to consider either tamsulosin or silodosin rather than alfuzosin. And coming to co-administration of these alpha blockers with other antihypertensives, these highly selective third generation alpha blockers, they can be safely prescribed to patients who are on antihypertensives. They will not cause additive effect of hypotension in them. Alpha blockers in pregnancy, the safety has not been studied because in animal studies, they have shown that there are no teratogenic effects to tamsulosin or silodosin or even alfuzosin. But the current recommendations say that these drugs should not be given in pregnancy. Now, in pediatric age group also, the safety has not been studied. Even in reduced doses also, these drugs should not be considered in pediatric age group. Coming to prescribing, before prescribing any alpha blockers, the most important thing is you have to take a detailed history, whether the lower urinary tract symptoms are associated with the symptoms are mixed or storage symptoms or voiding are there. You have to characterize the nocturia. What is the reason for that? You have to evaluate. The severity and bother of these symptoms should also be studied. For mild lower urinary tract symptoms, generally conservative measures can be done without the need for any drug. And coming associated comorbidities, you have to look, like I already mentioned, like CKD and CLD. And drug history, this is very important, which most of the people miss. So always at least cytochrome P450 inhibitors like ketoconazole and the itraconazole and other antiviral drugs when the patient is on, you should have to be careful. One thing which is important is whether the patient is sexually active or not. So sexual function should also be, history to be taken. And in such cases, preferably you have to choose an alpha blocker accordingly. And of course, basic investigations I don't want to highlight. Yes, you all know, but if the gland size is bigger, then you have to go for combination. And of course, cost issues also we should not forget. Sometimes patients who are not affording costly medications, and you have to go, since silodosin is costlier when compared to the other drugs. And this I already mentioned, the when to take the 30 minutes after a meal, anytime, but the timing should be fixed every day. If you want to take in the afternoon, you have to take in the afternoon only, every time. Now, this is sometimes there are patients who are not responding to 0.4 mg of tamsulosin. Sometimes a question is asked whether we can increase the dose of tamsulosin. Yes, there is a study which has shown that 0.4 and even 0.8 mg of tamsulosin can be prescribed to increase the efficacy of the drug in terms of relieving lower urinary tract symptoms. However, there is a slightly increased risk of having a cardiovascular effect in terms of symptomatic hypotension. Now, coming to the side effect, I think majority of the side effects, all of us know that when you go for tamsulosin, the incidence of abnormal ejaculation is around 8.4%, like projected in this slide. But however, the ejaculatory or retrograde dysfunction, retrograde ejaculation, and is significantly higher in patients who are on silodosin when compared to the other drugs. But provided alfuzosin is the drug which is doesn't have much of a ejaculatory problem or erectile dysfunction. Even studies have shown that alfuzosin improves erectile function. So that's why in patients who are sexually active, alfuzosin is a preferred drug. Now, when you go to treatment-related adverse effects, there are a lot of side effects which are seen in published literature, like headache, asthenia, and nervous system symptoms like dizziness, somnolence. These patients do complain. Once in a while, you land up having patients complaining about these things. Respiratory symptoms like rhinitis or pharyngitis, nasal stuffiness, these things patients do complain. And diarrhea and nausea, of course, abnormal ejaculation, which I have already mentioned, and the blurring of the vision. However, these symptoms are not so bothersome, needing discontinuation of the drug. Majority of the patients do continue the drugs. Only the problematic are the ejaculatory problems. One thing which I want to highlight with alpha blockers is the floppy iris syndrome. It is generally patients who are undergoing to cataract surgery. So they might have problem like the tendency of the iris to prolapse through the corneal incision, or they can have a flaccid iris stroma, which is actually undulating during surgery. And also even patients do develop progressive intraoperative miosis, leading to difficulty in placing the lens. So this can occur anytime after a patient on alpha blocker therapy. It is more commonly studied with tamsulosin. However, it has been even seen in with silodosin as well. So how to approach when a patient comes to a clinic who says that I am already planned for a cataract surgery in another 10 days, and he's also complaining of lower nerve symptoms, and the patient comes to you. So it's very important to discontinue the drug at least for 1 week prior to surgery. This may or may not prevent the problem of floppy iris syndrome. And almost whenever you are starting an alpha blocker to any patient, if he is planned for a cataract surgery, you should inform the ophthalmologist. And then it is better to delay the surgery. It is better to consider starting the alpha blockers after the cataract surgery rather than before. And alternately, you can go for a non-selective alpha blocker, like in this study where they have compared the incidence of intraoperative floppy syndrome with tamsulosin versus alfuzosin, and they found that the incidence of this syndrome is lesser in patients who are on alfuzosin because it is non-selective when compared to tamsulosin. And few final points, 1 or 2 points, like in patients who are sexually active, the alfuzosin has been proven role that it improves the rigidity of erection, and also the ejaculatory dysfunction also will not be there with alfuzosin, which has been proven in many studies. And if you need a rapid onset of action, like the published data always shows that the silodosin, since it attains the plasma concentration very rapidly, in this slide provided, you can see on the D figure, where even at 2 to 6 hours, the Qmax value significantly rise. So for faster action, you should prefer silodosin. Just the final slide showing the other indications of alpha blocker, like a patient who is on retention and for successful trial without catheter, you put them on alpha blocker, give a trial. For relieving stent-related symptoms, even silodosin has been shown to be beneficial in patients who are having premature ejaculation because it delays the intravaginal latency time and also it delays the ejaculation. And when patients who are specifically having significant nocturia, silodosin has shown in studies that it is better when compared to tamsulosin or other drugs. And of course, associated overactive bladder symptoms also, sometimes these drugs improve. And as a prophylactic therapy, also alpha blocker is given for patients undergoing hernia. Sometimes patients do come with an ultrasound report saying that they have an enlarged prostate. So to prevent the post-operative retention, the patient can be put up on alpha blockers. Thank you. I'm happy to answer
Thank you for your excellent presentation. So I would like to request Dr. Priyank Vargava and other residents, Dr. Bikram Singh from Jodhpur, who can interact with Dr. Sudhir. And also I want to request the expert to put their opinion and comments.
I have kept few questions, 1 or 2 questions. If you can agree, I can just even the residents who are participating in this session, they can answer these.
Yeah, Dr. Priyank. Dr. Priyank, you are there?
Yes, sir. Am I audible, sir?
Yes.
Yeah. Which of the following alpha blocker needs dose titration? So can you answer?
Yes, sir. Doxazosin will need dose titration, and the third generation alpha blockers do not require dose titration. That is their advantage.
Yeah. So you are rightly correct. You are absolutely correct. The doxazosin, yes, it has to need dose titration because of first dose effect actually. Coming to next question, the T max is least with which of the following alpha blocker? The T
Sir,
max
as you
will
rightly
be
Silodosin.
yes.
Silodosin, sir. Yes.
Silodosin has the shortest duration of
2 to 6 hours of Qmax immunity.
A 65-year-old male with BPH and LUTs and also had liver dysfunction of childbirth B. Which of the following drug has to be avoided in this patient?
Sir, alfuzosin should be avoided in these patients.
Alfuzosin.
Yes. So alfuzosin has a primarily significantly it is metabolized purely by the liver. So obviously alfuzosin should be avoided in patients with hepatic dysfunction. With moderate dysfunction, it should be avoided.
Yes, sir.
Whereas silodosin and
Yes, sir.
tamsulosin can be considered moderate dysfunction, the hepatic dysfunction, but not in severe dysfunction.
Yes, sir.
Tamsulosin is contraindicated with all of the following drugs except
Atenolol.
yeah, you are right. Like rest of the drugs are potent inhibitors of cytochrome P450 enzymes.
P450 inhibitor.
So we should not give this. Which alpha blocker you prefer in a patient who is sexually active?
Alfuzosin should be preferred, sir.
Yeah. Floppy iris syndrome is least with which of the following drug?
Silodosin, sir.
No, it is alfuzosin. Actually, alfuzosin is a non-selective blocker. So whereas with silodosin and tamsulosin also have been reported to have floppy iris syndrome.
But
You tell me.
yeah,
You have
sir. Actually, yes, sir. I had to ask one thing as well. I'm Sir Dr. Vikram from AIIMS Jodhpur in this joining this session. Sir, there are mainly 4 drugs that have been being labeled as causing floppy iris syndrome. Mainly tamsulosin, alfuzosin, doxazosin, and another 4th one is naftalin. So silodosin, I thought would be the answer of this because the least chances of floppy iris among these given drugs.
Generally, the floppy iris syndrome is predominantly because of the high, like if you take silodosin, tamsulosin, and alfuzosin, the selectivity of this drug is specifically on the iris only. So if you take a non-selective blocker, the least chances of floppy iris syndrome would be in a patient who is on a non-selective blocker. Like for example, the published data says that alfuzosin has lesser chance when
As
compared to other drugs.
Okay, sir.
Yes, I have shown the
As
study
compared
also.
to tamsulosin, yes, sir. Maximum is with tamsulosin, then comes alfuzosin, and
It's a. I was just telling it to be a least one, which would be alfuzosin rather than the rest. Okay.
okay, sir.
So ejaculatory dysfunction is highest with which of the following drug?
With silodosin.
Yeah. So that's why there have been studies also saying that the patients who had significant ejaculatory dysfunction following silodosin, they have better improvement in lower urinary tract symptoms when compared to a patient who had a lesser ejaculatory dysfunction, because the drug is more effective in those patients because it is relaxing the bladder neck and everything. That's it. Any other additional questions you can ask?
Sir, I had one question regarding this. As you have mentioned that in the well-controlled hypertensive patients, the alpha blockers, mainly tamsulosin and silodosin, they don't interfere much with the hypotension part. And so, if at all, if a patient comes to OPD and who is having an uncontrolled hypertension and being diagnosed in the OPD only while examining his BP, and then what should be our priority? Should we proceed with giving medication for the BPH, that is tamsulosin or silodosin, or we should get a medical consultation regarding control of BP first, then we should proceed with prescribing the alpha blocker?
I mean, based on the data, published data, if you see patients who are already hypertensive, who are not controlled, not at
Yes,
control, even if you give alpha blocker, the effect of this alpha blocker on the hypertension would not be much because they are highly selective because they have less action on the alpha 1b receptors.
Alpha 1b receptors, yes.
So, I mean, whether to give now or not, that depends on the patient's symptoms. If the patient is significantly bothered, you can straight away start the third generation drugs, which are not going to affect. But at the same time, obviously, you have to control his
BP.
blood pressure also parallelly.
Yes, sir.
But if you take the other drugs, which are the older generation drugs, they specifically mention that if you in that only one drug is enough, because the drug itself can act for both. It can
Yes,
even
sir.
reduce blood pressure at the
BP.
same time it can relieve the symptoms as well.
Yes, sir.
But in these newer generation, you have to add another extra hypertensive drug as well.
Okay, sir. Yes.
There is a
Thank you.
question in the chat box as well. When can you stop giving the alpha blocker? In other words, when would you say that the alpha blocker has been ineffective in treating the LUTs?
Generally, if you see the mechanism of action in all the published studies, the effect of alpha blocker actually it is progressive till 12 weeks. After that, generally it plateaus. So if in a given patient you have started on a drug and you are seeing that he says mild, I have improvement in symptoms at 4 weeks, then you can wait for further time till 12 weeks. Even after that also, if the patient says that I am not improving, then you have to consider other options, like either you increase the dose, like particularly for tamsulosin, if the patient is willing for taking the increase in the dose, you can consider the increase in dose of the drug, or else you have to go for the other, because medically he's not responding, you have to reevaluate him, maybe that he might benefit more with a surgery rather than a drug.
And is there any difference in prescription for a male versus a female?
So the alpha blocker role in females actually is not proven, to be frank.
Question is out of
The main
and this is one of the
I mean,
difficult question to answer.
most of the times we, in few patients we give them, I would somehow feel practically with our experience, I feel that the alpha blocker in female would be more of a placebo effect rather than the definitive effect in them. So I would preferably be, based on the evidence, I would say that it's not recommended, particularly in females. It's not of much use, to be frank.
So as per literature, if I may add here, as per literature, the females may not respond as well because the concentration of the alpha receptors is not as much as in a male. But when it comes to treating LUTs, there are no other additional medicines available to us. So there are studies, although not good level evidence, but still they show that some females do respond to alpha blockers, and the side effect profile is would be there as in males, and obviously the sexual side effects are not there. So there is no harm in trying the alpha blockers as such from the clinical point of view. But as correctly said, there is no high level evidence to back up that use. Okay, so Dr. Apul, Dr. Nachiket, do you have any other comments or questions, please?
So, very nice presentation, Sudhir. So, just to carry forward the discussion on hypertension. So, Mini Press XL, which is prazosin, works for both hypertension and for BPH as well. So, but I see that we are not prescribing Minipress XL anymore. So, and a substantial number of elderly patients are hypertensive as well. So, I fail to understand why this has happened. So, giving one drug which is working for both the conditions would be a better choice rather than giving two drugs separately, one for hypertension and another for BPH. So, what's your take on that?
Yes, sir. But if you see
Well, if I can, I would also like to add something regarding what Apul sir has said. I think that so cardiologists, they have got multiple set of drugs in which they can treat their hypertension, because as urologists we always are just fixated with alpha blockers. Why are we giving alpha blockers? Like doxazosin. Again, doxazosin and prazosin, they will cause more hypertension, and again, a dose titration would be required. That is the whole reason why Minipress XL came. And I think that if you talk to your cardiologist, then he'll be more than happy to, they have membrane stabilizers, calcium channel blockers, aldosterone receptor. They have a myriad of drugs which, they can control their hypertension with. So, as a rule inside our SMS, what we do is that we, we continue with our alpha blockers, and when the patient goes to cardiologist, then we tell the patient that, ask him that as we're already giving you alpha blockers, then he can control his blood pressure. And majority of the times they are able to control their blood pressure of the patients with the other variety of drugs that they had. So I don't think that, personally, I don't think it's a big major issue, inside that.
Yeah, I also agree, sir. This point actually, this always comes into doubt. When you see the older publications, it's always mentioned that it acts on both. Then why not to? Since you are getting an extended release formulation, and the only problem is preservation is the short duration of action in the previous short acting drug. But now since you have the extended release formulation, it would work actually to both. I think we have to explore that. I don't know actually. I don't have a practical experience to say any patient who is on that and how he responded. Did we avoided any alpha blocker in him or not?
So I think Cardivas, the doxazosin is still available. I'm not sure whether Terazosin or Hytrin is now there on the market, but Cardivas I think is still there. And some old
But
Cardivas.
again, doxazosin would require a dose titration. You have to
Yes,
start it
yes.
with 2.5, then give 5. So
That is
again,
happening.
I mean, you're going back. I'd like to add one point, what's important point to our residents, and that is that there is no efficacy inside the, working of any kind of alpha blocker, be it the latest one, salidocin, being it phenoxybenzamine, which was introduced 50 years ago. I mean, if you look in the papers which have compared, say, even doxazosin, prazosin, terazosin, or even salidocin, I mean, there's not difference. The only difference again is the side effect profile. So because you do not have to titrate these, the patients you're sure that do not have any hypotension, the incidence of side effects per se is negligent inside the newer drugs. So efficacy wise, if you're if you look into the efficacy, there are no difference in the oldest drug, but it's just the side effects are pretty less inside the newer drugs. So this is also a very important message that you should remember. You can get bombarded by all type of studies which will forget the efficacy of the older drugs. But if you look into the results or the studies which were done in the late 90s, early 2000s, still there is no difference in the efficacy. And as far as the side effect, for example, in salidocin, they say that it's safe inside cardiac patients. How many of us would refer a patient before starting salidocin to get his QTC interval tested? I think that we are not sending any of our patients, to the cardiologist. Look, I plan to start him salidocin and kindly see his QTC interval and whether there's going to be a change in his QTC interval or not. So I think many of these side effects also that are industry driven, like naftopetil. I mean, when naftopetil couldn't find, a place inside clinical practice, then they started, saying that naftopetil is very good for nocturia. And still, I mean, efficacy wise, it was the same as salidocin or tamsulosin, but it didn't fit into, say, a narrative which was given to us from the industry. So the residents have to remember that, efficacy wise, it's very, very important. They tend to forget this thing that you can give a patient a drug which is cheaper, like tamsulosin, vis-a-vis the salidocin, expect the same, efficacy. So you have to be very, very, particular about even it's long treatment. It's going to potentially affect the, money is involved. Patient is going to take this drug for years on. So it's
Ram
important to
Gopal.
remember this.
Yeah. My short question to Dr. Sudhir at the same time, um, with rampant use of all these alpha blockers, we are using mainly three. Now, is there any specific indication of doxazocine which is there at present?
There is, sir, but coming with specific indication for doxazosin as such, I don't think there is anything. It is like that because
Where do you
now,
recommend it to be used nowadays? Any group of patient?
just a second, sir. Sorry. Yeah, I was getting a call. Sorry, sir. Any group of specific patients you are telling about? I mean, I have never prescribed doxazosin, to be frank, but if you ask me, if at all you want to give, then I would consider like in a patient where the patient is hypertensive at the same time and you want to affect with this also both. I think such type of patients where like we are discussing the controlling hypertension at the same time you want the LUTs also to be improved. I think in such scenarios, maybe we can consider it. I mean, rest of the thing, I don't think that it has any use in other areas, basically.
Yeah, so the only patient, so maybe if he wants to really reduce his pill burden and only has a small amplitude of hypertension to be controlled, as well as the LUTs are not too significant. So maybe that specific kind of a patient one may use. But okay, so thank you very much. I think we have come to the close of today's workshop, and I thank all the senior faculty members and teachers who have agreed to be part of this, and also the students who have actively taken part in this entire activity. I know we have shoot on the time a little bit, but I think it was a time well spent. The students learned out of this activity. We are open to any comments or critiques or changes that you may like to see in the subsequent programs. You can write to any one of us in the council or directly to me also. You can WhatsApp me or email me on my official email address. I would be happy to bring in the changes that the members want to see. So with this, I would say thank you to everybody. And sir.
Yeah, make one suggestion.
Sir.
You and people both see. You see, you put that the clinical presentation prize for the residents. Similarly, you put the discussion also. So the residents will be involved in whole of the workshop or your program you are in. So whosoever is doing a good discussion in that one, that should also a prize should be given to that resident also.
Yes, sir. So we are not going to restrict it to only the clinical case discussion. We are going to see the entire workshop.
Yeah, that will be fine.
And probably we would give it to the institute rather than the individual resident, so that the institute, all the residents feel that the motivation to participate.
Okay.
So any other suggestions you feel that we should incorporate, we are open to incorporating them, and we will definitely do.
Sir, I think we can put a feedback form on the website or in the groups, and that feedback form can be distributed among all the participants and all the members, so they can put their feedback.
Dr. Washington wants to say something.
Some Google form can be given as a feedback form, and that can be part of our curriculum.
Sure.
Yeah, so I think, Rishi, it's a great initiative on the part of North Zone Council, and especially you, Sanjay, and Prikpal, who have taken the lead. And I must say that it's an ongoing process. So as the time will go, the things will keep on changing. The observation is that good job has been done by all the presenters and the experts, and more interaction is required from the resident side. So how we will plan it, that resident participate, as Professor Bhatt has suggested, that awarding and rewarding them would encourage more and more participation. But the goal of this whole exercise is that bridging the gaps. We have gaps in both teaching, training, as well as research affiliations. So if we can improve all these aspects of soft skills, you have done excellent balancing act of including different things. But definitely for residents, I'm sure this will work as a platform, and wish you all a very best for future programs. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, everyone. We close the session, and good afternoon.
Thank you very much.
Thank you, everyone.
Thanks.
Stay safe, stay healthy.
Yeah.
Thank you.
Thank you.
Thank you all. Thank you.
Enjoy Makar
Thank you.
Sankranti. Thank you.
Thank you. Thank you.